Started. Oops. Oh, there we go. We're going to get started. Nobody on the other side heard that. Welcome to the meeting of the Mental Health Services Oversight and Accountability Commission. My name is Mara Madrigal-Weiss, and I am the chair of the commission. I want to thank you for attending. The commission's strategic plan for 2020 through 2023 is committed to 3 strategic goals and objectives to advance the commission's vision of well-being for all Californians. Cody, can you please bring up the strategic goal slide? Thank you, Cody. Now we will take roll and establish a quorum. Amariani, can you please take roll?
Yes, okay. Commissioner Bontrager. Commissioner Boyd. Commissioner Brown.
Here.
Commissioner Bunch.
Present.
Commissioner Carnevale. Commissioner Carrillo. Commissioner Chambers.
Present.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Here.
Commissioner Gordon.
Here.
Commissioner Roulette.
Present.
Commissioner Tamplin.
Here.
Vice Chair Alvarez.
Here.
And Chair Madrigal-Weiss.
Here.
And then Commissioner Cortese.
Here.
We have a quorum.
Thank you, Amariani. We are now moving to agenda item number 2, announcements and committee updates. At this time, I would like to make a few announcements. The August 2022 commission meeting recording is now available on our website. The next commission meeting will take place on October 27th in Sacramento, and we will have a site visit to a full service partnership program, as well as a site visit to a school wellness center. At this time, I would like to invite Commissioner Tamplin to say a few words on the passing of Sally Zinman, as well as an update on the fellowship that the commission has created.
Thank you, Chair Madrigal-Weiss. It's with a heavy heart to share with everyone that on August 25th, the world lost a pioneer and trailblazer within the mental health consumer, survivor, ex-patient, peer movement. Sally Zinman transitioned to the realm of our ancestors with her daughter, Rachel Harris, holding her hand. Sally was a dear friend and part of my peer family, so my apologies because this is a tough time. We stand on the shoulders of Sally as she was instrumental in getting the Mental Health Services Act passed. She dedicated her life to transforming mental health services. She was a survivor of trauma within mental health treatment and came out dedicating again her life to this work. She promoted a mental health system that offers more voluntary, person-centered, holistic services that deal with the whole human being. And she was a strong voice for recovery and services that promote access to employment, secure housing, education, social connections, and good health care. Sally was known for fighting tirelessly for the protection of our rights and the promotion of voluntary services. I had the privilege and honor to work with her closely for the last 15 years. We all know how much Sally was instrumental in policy development and supporting bills like SB 803 that allows peer support specialists to get certified and be employed throughout our systems and valued. She also was a strong advocate, again, for, I would say, a diversion from more court order treatments and, again, more voluntary services. She walked the talk of the peer movement's values that included self-determination, empowerment, hope, peer support, just to name a few. And it was, she just didn't talk it. She really made sure policies and bills and the environment that she was in upheld that. I will always cherish her friendship, the wisdom and knowledge she shared, and dedication and her leadership on her commitment to this movement. And, in addition to all of these, I think, something that many people don't know, unless you've been to a conference with Sally, is that she loved to dance. She would be at every peer conference on the dance floor, and first on the dance floor and last to leave. She lived in Alameda County, was a leader within our Peers Organizing Community Change, POCC group that has over 1,600 members. And core to her heart was bringing people together, bringing peers together to make sure people knew they were not alone, that they had a community, and that we, can unite to help improve services. In addition to being the founder and first executive director of the California Association of Mental Health Peer-Run Organization, Sally has over 4 decades of leadership in our state and across the nation. And something I'm proud of is she was one of the first members of the Client Family Leadership Committee. So Vice Chair of the CFLC, Commissioner Chambers, and I had the privilege to work with her on in the committee. And just thank you, Chair Madrigal-Weiss, for this time. I do hope, during our public comment period or anytime, if any other commissioners would like to share something about Sally, that would be possible. And if we could take, a moment of silence in her honor. Take that now for 30 seconds. Thank you.
Thank you, Commissioner Templin, for those words. Is there any other commissioner that would like to make a comment? Please, Commissioner Chambers.
I just want to say that I was very honored to know Sally Zinman. As a young advocate in the peer movement, she afforded me the opportunity to work with her and CAMPRO to really lift the voice for peers with SB 803, encouraged our organization to go after the Medi-Cal certification so that we could be trailblazers in training the peers in the ethics and core competencies to be able to address some of the most complex challenges that peers and individuals with lived experience are facing. I also had the honor to work with her in advocating for psychiatric advance directives and organizing the peer voice around our rights and preventing as much as we could involuntary care for individuals like myself with serious mental illness. Sally also worked with me as a young African-American leader and really supported me when other individuals were apprehensive to work with me. And I will never forget that. And one of my last conversations with her, because I was frustrated as an executive director about not being able in this first round to implement SB 803 in the service. But she's like, you got the training certificate, and Rachel, I might not be able to see it, but you will be implementing SB 803 in LA County and across the state. You will get to have the governor, stand with the governor and sign psychiatric advance directives. So my charge with Sally is to make sure in her honor that that bill gets passed and with the governor, and that we're standing there in her honor. So I just want to say, for those that, are apprehensive to work with young leaders, embody the spirit of Sally Zinman and take an opportunity and a chance to reach out to a young person or to an individual and take their hand and mentor them, because she really did that for me. And I just want to honor and lift that. And plus she's from the Bay and I'm from the Bay too. So shout out to the Bay. Thank you.
Thank you, Commissioner Chambers. Any, please.
A slightly different perspective. Sally was, as my fellow commissioners have said, the epitome of an advocate. She was given our organization is a provider of service. She was relentless in ensuring that peers had a voice in every area. She epitomized nothing about us without us. That was clearly manifested in the walk of Sally's life. The organization that I'm associated with, Turning Point, was the Turning Point Community Programs. The trajectory of the organization was influenced by Sally Zinman and her advocacy and support for people of color, people with lived experience. And she, again, underscored the importance of ensuring that people with lived experience not only were represented in the organization, but led organizations. And so I ditto the remarks of my colleagues, the fellow commissioners.
Commissioner Rowett. Yes, please, Commissioner Brown.
I think I'll preface this by saying I think I'm the longest serving commissioner now on the commission. And what's interesting is to see how many of the people who were either on the commission or were regulars in addressing the commission, how many of them have left us. And Sally now joins those ranks. But I also think that she leaves a great legacy in Commissioner Tamplin and Commissioner Chambers and others who she's had such a tremendous influence on. And it's this whole pay it forward notion that all of us have a finite amount of time on this earth, and all of us have only so much that we can give. But if you invest some of that time and inspire others, it's paid forward, and your contribution continues. And I think she's a great example of that.
Thank you, Commissioner Brown. Thank you, my fellow commissioners, for those comments. I want to say that in the 5 years that I've been here, Sally definitely stood out. And the first time I ever heard that saying nothing about us without us was from Sally. In June, I was at a conference in DC and she received an award there. And it was a standing ovation for her work. And, seeing her here in the commission meetings and then seeing her get that award in DC and bring the house down in applause, and she's nationally recognized. We're all proud of her here in California, but to see that, I was ecstatic to see that. And, go Callie, go Sally. So absolutely, she is a great hero of ours and of the movement. So thank you for those words. Thank everybody, all my fellow commissioners. And so with that, we will continue to move on. At this time, I would like to ask Tom Orrick to please share with us information regarding new staff. Thank you, Tom.
Great. Thank you, Chair Madrigal-Weiss. I'm happy to introduce you to two of our newest staff members. You can come right up here so we can see you. This is Shantae Rhyme, and this is Ivana McIntosh. And Shantae is a retired annuitant. She has done over 25 years of service at the state of California. And she has expertise in program administration, procurement, contracts. This is going to be very helpful to have her expertise here. So we're very happy to have her. Her education is in business administration and juvenile justice. And so she chose to come here to the commission because she was attracted to by our programs for youth. And so with that, we plugged her right in, and she's going to be helping with our Alcove Youth Drop-In Center. She'll be our lead on that project. And so we're very happy to have Shantae here. She enjoys traveling. We all do. That's great. Spending time with her family and her fur baby, Oliver. We haven't met Oliver yet, but he sounds like a good guy. Yes. And we also want to introduce you to Ivana McIntosh. We're happy to welcome Ivana here. She actually hasn't started yet. She's not officially started, but she wanted to come by and say hi. and see what we do here.
Tom, we lost you.
Hi, everyone. Sorry about that. I think we have some technical difficulties. We will get that back up in just a second.
Hi, this is Mark Carlitz, and wonder if I can make a comment on Sally.
Hi, Mark. We're not taking public comment at this time.
Okay.
The chair will call for that in a few. So thanks a
All
lot.
right, thank you.
Thanks, Mark.
Year in the MHSSA program, and so it will be exciting to see the progress made and gather feedback regarding the Wellness Center program model. This is the first of several site visits to our MHSSA programs. In the coming months, we hope to visit the Wellness Centers in Ventura County. More information will be sent out to commissioners in the coming days and weeks. Beach City's Alcove ribbon cutting ceremony. I'm excited to announce that one of the commission's Alcove Youth Drop-In Center programs will be cutting the ribbon on their new center in October. The center is located in Los Angeles County and operated by the Beach Cities Healthcare District. As you may remember, the commission issued grants to 5 programs that will provide health, mental health, education support, peer counseling, case management, and drug and alcohol counseling in one location. These programs are designed by youth and for youth, so they look nothing like the typical sterile clinics that we sometimes see in our systems. These centers are innovative and show great promise to increase access to services for young people, which is so important at this time. We will be hearing more on the specifics of the ribbon cutting at Beach Cities so that commissioners can attend. KVIE. Last meeting, I announced that the commission, in conjunction with PBS, KVIE, and community mental health partners, will be hosting a special screening and panel discussion of Ken Burns' recent documentary, Hiding in Plain Sight, Youth Mental Illness. I just wanted to remind everyone that that evening is tonight. So at 5:30 p.m. at the Sophia Theater here in Sacramento. I hope everyone will be able to stay to experience this 30-minute screening of the film, followed by a panel discussion with representatives of the film, including director Christopher Ewers and youth film subject Morgan Brennan, as they discuss the crisis live on stage. At this point, we will hear updates from our committees and subcommittees. I would like to invite Vice Chair Alvarez, then Commissioner Tamplin to provide their committee updates.
Thank you, Chair Madrigal-Weiss. The Cultural and Linguistic Competency Committee last met on September 8th, so just a couple of weeks ago. We had the opportunity to hear from one of the commission's advocacy contractor, the California Pan-Ethnic Health Network, which was specifically provided by Vincent Chu and Carolina Valle from their team. What they came to talk to the CLCC about was their Right to Heal project, which included their findings from year
All right, sorry, folks. I think we're having some internet connection issues here at the office. We will get the meeting back up. Sorry about that.
While we can't hear, is the meeting still happening?
They they are still going, Commissioner Bunch, but I think they know that they got booted off the Zoom.
If the lapses are just going to be brief, where in a couple of minutes we'll be back up, is there a way for them to pause it until we're back on, particularly when the meeting gets started, so we're not missing anything?
Yeah, I think they got alerted the first time, and I think they know about it now as well. So I think they paused. We're kind of communicating over here on our end.
Madrigal Weiss. The Client and Family Leadership Committee met on Tuesday of this week. Vice Chair Commissioner Chambers of the CFLC and I, we heard with committee members an update on care courts legislation, which was recently signed into law. This discussion was centered around steps we can take to advise the commission on strategies to take some pressure off the care courts by focusing on more upstream prevention services that would be offered through our FSP programs, our SB 802 priorities. We also, talked about the need for more peer respites in every county and city, crisis residential centers, and protection of rights for those that end up in care courts, and clarity on how to support people not get stuck in any kind of court order treatment, but help them transition into the community voluntary services that we feel are very effective. I look forward to today's discussion on changes to the Commission's SB 802, SB 82 program, and how we might prioritize funding to address early intervention. The committee also heard an update on the peer certification resource guide that will be provided to counties and CBOs to guide their efforts to implement peer specialist certification. And we, of course, took time to remember Sally Zimmern and highlighted the values and qualities that Sally has demonstrated in her work and her life as a true champion for mental health consumers and mental health system as a whole. We stand on her shoulders and look forward to carrying on those values that she modeled. And the CFLC will meet again. We were given some feedback from our stakeholders that our meeting was conflicting with other meetings. So we have October 25th set, but we may be considering October 24th. So that will be determined pretty soon. And then we'll also be meeting in November 15th, because we have a lot of work to get done, especially with our peer certification resource guide. And our Vice Chair Chambers, if there's anything I missed, if you'd like to add.
I think you covered everything. The biggest part was ensuring that we bring back as much feedback to the commission and that the commission is open to hearing about, like Ms. Tamplin said, about other strategies that prevent individuals from going into involuntary care, like peer respites, emergency psychiatric units, crisis residential centers, and more funding for CBOs. So that'll be some of our really big push and information to the commission, and how we can really push for some of the funding that we advocate for to go to CBOs, and to support counties, but also support CBOs. Thank you.
Thank you, Commissioners Tamplin and Chambers. At this time, I do.
Chair Madrigal-Wise, apologies, I also have a division committee report.
Please, Commissioner Danovich.
All right, thank you. So this is a report regarding the Research and Evaluation Division. So with respect to school mental health and the Mental Health the Mental Health Student Services Act, the Research and Evaluation Division team is working with community engagement and with the grants team on a unified community engagement strategy to inform the evaluation and technical assistance components of the MHSA. The team sent out a request for qualifications to prospective external evaluators for the MHSSA evaluation and has received 6 responses over the next few weeks. Those responses are going to be reviewed, scored, narrowed down. The Research and Evaluation Committee work group over MHSSA will be asked to review and weigh in on the selection process for those evaluators. The MHSSA work group will be convening on October 5th, which is a Wednesday from 1 to 2:30 p.m. And that meeting is open to the public. The purpose of this work group is to provide guidance to staff and the commission on evaluation of the MHSSA. The first meeting is going to be focused on developing a theory of change as a foundational component for subsequent evaluation efforts. With respect to triage, there's ongoing data collection and analysis going on for the summative evaluation of triage. And with respect to FSP programs we support, in preparation for a November 15th report to the legislature on FSP, Research and Evaluation Division staff are working on a write-up, which will be shared, I believe, at the October meeting. With respect to data and infrastructure, Research and Evaluation Division staff have been refining several of the dashboards within the Transparency Suite, such as the Innovation Dashboard, so that information is more usable and more clear. The Data Warehouse team has received a California Department of Education, Employment Development Department, and Vital Statistics has received data from all of these departments and has been working on linkages to the client services information data. These linkages are going to allow answers to specific evaluative questions, such as, did school attendance increase for youth who received mental health services through school-based mental health? Right. The problem that we constantly face is that the data that is needed to answer questions like that is housed in different databases, and so those databases have to be linked so the data can be turned into information that's intelligible, and then that information can be turned into knowledge that we use to understand how things are performing and where there are opportunities. And then finally, the next Research and Evaluation Committee meeting is currently being planned. We don't have a date for it yet. The aim is to have it the beginning of next year. Before that, the meeting is convened, the chief of the Research and Evaluation Division, with input from the chair, myself, and my co-chair, are going to be providing additional clarification on exactly what we hope the committee to be doing and how it's going to be supporting the Research and Evaluation Division portfolio. So that's my report out. Thank you.
Thank you, Commissioner Danovich, and appreciate the work that you are leading in this area. And want to say that, you know, there's a lot of attention on the school-based MHSSA. So really appreciate that we are looking at getting outside evaluators to really start to evaluate this work. And in regard to linking the data, could not agree with you more. Everybody's counting kiwis, oranges, apples, and everything else, and we really need to bring it together. So thank you for that update, and I apologize that I did not have that.
No problem. And it's really the leadership of Melissa and the division staff that Commissioner Carnevale and I aim to support.
I apologize for not including Melissa, staff, and my commissioner. Well, so thank you. I also want to apologize. I understand we're having technical difficulties and you're not necessarily seeing the room from the Zoom side of things. So I apologize for that. I know you can hear our voices, so please, I know they're working on it. So we will continue. Also, just to catch up on time, the updates for PEI are in the documents, as well as the update for the Children's Committee. I did want to provide the update in regard to the Firearm Violence Subcommittee. At the last commission meeting, commissioners formed a subcommittee to explore opportunities to address the mental health impacts of firearm violence. At that meeting, I appointed Commissioner Keandra Bunch as the chair of that subcommittee. Since that discussion, Commissioner Brown has expressed interest in serving as the subcommittee's vice chair. I'm appointing Commissioner and Santa Barbara County Sheriff Bill Brown as the vice chair for that subcommittee. So thank you so much, Commissioner Brown. At this time, I'm going to ask, do any commissioners have any additional updates that they would like to make? I see none in the room. I see none in the Zoom room. So we are going to move forward. With that, I want to welcome everyone again to today's meeting. Recognizing that teleconferences can be very challenging, the plan is to end at 12:45 or soon thereafter. Commissioners, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so that the commission staff can make you a co-host again. If you have a comment to provide, please unmute your line and seek recognition when it is convenient. It is now time for agenda item number 3, general public comment. This time is reserved for comments on items that are not on the agenda. If anyone is interested in making public comment regarding the announcements or other items, please make those during this public comment time. If you have any technical questions, please contact us at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that agenda item. When it is your turn to comment on that agenda item, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take the comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. Chair Madrigal-Weiss, I hand it back to you.
Thank you, Amariani. Would you please open the line for general public comment?
Okay. Okay, Mary Ann, your line is open. You may go ahead.
Thank you. I'm Marianne Bernard, retired lawyer and advocate for the severely mentally ill, SMI, as that is defined in MHSA, former counsel to mental hospitals in another state, and counsel and co-plaintiff with Rose King, one of the drafters of MHSA, of the lawsuit that forced the No Place Like Home amendments to the ballot in 2018. As I have reminded you all before, MHSA Section 5840C, last clause, mandates, meaning it is not a choice, that PEI shall include programs that, quote, reduce the duration of untreated severe mental illnesses and assist people in quickly regaining productive lives, close quote. In other words, relapse prevention for consumers who are already severely mentally ill is mandatory for PEI and is included in existing regulations for that reason. Consequently, I was very sad to see that the August draft of your PEI document, which defines relapse prevention as tertiary prevention at page 17, skips it entirely in the priorities that follow. There is only one confusing and misleading mention of it at page 59, which says that the Wellness Act funds crisis PEI, but fails to mention that MHSA both funds and mandates these services. That whole section needs to be refocused on PEI for existing illnesses, or it is pointless to include it in the document. Most importantly, 1 year ago, the California courts ordered, and the legislature has since been scrambling to create diversion and reentry programs for SMIs who have for years been warehoused and treated horribly in our jails and prisons. MHSA has always contained another completely ignored mandate, meaning again, it is not supposed to be a choice. Section 5813.5F says that MHSA shall include services similar to the Mentally Ill Offender Crime Reduction Grant Program, recently clarified by the legislature to include services for, quote, pre-sentencing or post-sentencing programs, parole, probation, post-release, or mandatory supervision, close quote, and openly defined. Now, I see that you are trying to use money efficiently. That is a good thing. Crisis intervention centers and jails are where you find the revolving door consumers who desperately need relapse prevention services. So significant MHSA PEI money should be focused on relapse services for
Marianne,
those
time
people.
is up.
And I will finish my thought. If you focus money on those services, it will save lives and avoid human misery for SMIs, for their loved ones, and for those that they harm, which is why so many of them end up in jail to begin with, and they don't belong there. MHSA mandates this. It has always mandated it. It is part of your jobs, so please see to it. And if anyone has questions about what the legislature has been doing, I am happy to answer.
Please wrap.
Thank you, Marianne.
Okay, next we have the phone number ending in 718. Your line is open. You may go ahead.
Hi, can you hear me?
Yes, we can.
Good. This is Steve Leone, client and advocate. I wanted to talk briefly about Sally Zinman. I mean, everything that Commissioner Tamplin said is so true, and then more besides. I'd just like to add, I first met Sally in 1984. She was already a major recognized state leader in the client movement, and I was on my maiden flight as an advocate in my then home county of San Francisco. And I've known Sally all these years off and on. I've worked with her in many places and times. And she certainly has been like a true north in the client movement, you know, like the compass, like for where most of us are all going, you know. And that needs to be recognized. There's something that's not been said yet that has always impressed me over the years. And that is she brought people together. People trusted her, especially in the early client movement. People had been abused by so many people, you know, and not listened to, especially back then. And And so even amongst people in the client movement, there was oftentimes a lack of trust. Sally was able to get that trust in a way no one else had. And she served for many years as a leader in the client movement with that trust. And I think that's an incredible accomplishment and needs to be remembered. Thank you, Sally. And
Thank you, Steve.
Okay, next we have Stacy. Your line is open. You may go ahead.
At the last commission meeting, I announced and invited all of you to a very, very special convening in Los Angeles on Friday, October 14th. This will be a conference called Culture is Health, and it will involve all the participating organizations of the California Reducing Disparities Project. The focus of this convening will be the preliminary results of the statewide evaluation that is being conducted by Dr. Cheryl Grills and her team from Loyola Marymount University. Space was limited, but every commissioner will be receiving a personal invitation from Dr. Rohan Radhakrishna, Deputy Director and Chief Equity Officer at the Department of Public Health. I know some invitations have gone out, so I hope you have received yours or will be receiving it before the weekend. I really hope particularly you Southern California commissioners will be able to attend. Although celebrated and preferred by many BIPOC and LGBT communities, we have heard that there may be some skepticism or perhaps unfamiliarity by some commissioners regarding community-defined evidence practices. Please, please come to this conference and learn about the research and these wonderful, wonderful programs. This interactive and educational meeting will bring together CRDP organizations, along with a collaborative of mental health professionals, researchers, policymakers, and community-based organizations to strengthen partnerships and create opportunities for knowledge exchange on innovative mental health prevention and early intervention solutions. I believe the main presentations may be live streamed, but I'm sorry, I'm not positive. Again, I hope many of the commissioners can attend this event. Thank you so much.
Thank you, Stacy.
Next, we have Richard. Your line is open. You may go ahead.
Good morning, commissioners. This is Richard Gallo from Santa Cruz, California. I am a person with lived experience and a volunteer with Access California, the program of Cal Voices. I wanted to express my concerns on behalf of families on the Central Coast of Santa Cruz, Monterey, San Benito, and Santa Clara counties, who families, both children and adults of dual diagnosis, mental health, and intellectual disabilities, at their struggle of having access to mental health services for their child or adult child in our communities. I strongly believe that they're being left out to the MHSA, where there's a potential for funding to help meet that gap for these families to maintain their child or adult child in meeting the needs of their mental health. Secondly, I believe that CareCorps is not intended for MHSA funding to be used. So the commissioner needs to go back and look what the intent of the MHSA funding is for. You need to be careful what you're going to be funded for, because it's not intended for CareCorps. Thank you very much and have a good day, everyone.
Thank you, Richard.
Next, we have Maya. Your line is open. You may go ahead.
Hi, yes, my name is Mia Bray. I am a graduate student at the University of Alabama at Birmingham. I'm also an intern at Remco and a transition age youth living in Sacramento. I would just like to request that a review of the PEI Subcommittee draft report regarding SB 1004 be put on the agenda for the next CLCC meeting on October 18th. Thank you so much.
Thank you, Mia.
Steve, your line is open. You may go ahead.
Thank you for giving me a moment to speak. Steve Dilley with the Veterans Art Project, and as a funded MASOC innovation project, I would like to invite the commissioners to come to our Capitol event on October 12th. We're going to have music, spoken word, singing, drum circles, static displays of veteran art, and anyone who's in Sacramento, I hope you can make it. And that will be October 12th from 10 to 4. Thank you. Have a nice day.
Thank you, Steve.
Next, Sauna, your line is open. You may go ahead.
Thank you. Good morning, everyone. My name is Zana Nuru Bates, and my pronouns are they, them, and theirs. And I am the new statewide advocacy liaison at Access California with Cal Voices. And this is my first MHS OAC meeting, so I wanted to introduce myself and meet the commissioners. I'm looking forward to the rest of this meeting and attending future ones. Thank you.
Thank you, Zana.
Hi, this is Mark Carmet.
I'm sorry. Sorry, we'll get back to you 1 second. The next raised hand, we have April. Your line is open. You may go ahead.
Hi, my name is April Bryce. I work with Zana, and I am the new Advocacy Director with Access California. We're a statewide advocacy program. We're based in Sacramento, California, but we're all over. We have people all over. I just wanted to introduce myself to the commission, and Zana and I will be here with you going forward, and we're really excited to see the work going on and be a part of it. Thank you, everyone.
Thank you, April.
That was the last final public comment. Yes, we'll get Mark. I believe your line is unmuted.
Yeah, this is Mark Carmet. I want to make a comment on Sally, and also I have a question for Stacy about that conference and what I didn't catch what it was called, and I would like to hear that so maybe we can attend.
That'll go into minutes, and the information will be on there, so you'll get that information. So did you want to make a public comment?
Yeah, basically Sally was quite a soldier, and we have to honor, she's one of the parents of the client movement. And when we were doing the videos with, I forgot the name of the organization, but she was a part of that. White Light Communications, she was on there several times. So promoting self-help and client-run services and peer-run programs. We need to continue with her work. We need to take a look at what she did and move it forward. So thank you.
Thank you, Mark.
And that was our last final comment.
Thank you, Amariani. Thank everybody for their public comments. We appreciate them. At this time, we are going to move on to item number 4. The commission will now move to consider approval of the minutes from August 25th. At this time, I would like to invite commissioners to offer comments or ask any questions. Seeing none, now is the time that members of the public may request to make a public comment on agenda item number 4 by clicking the raise hand button on your computer or the app, or if calling in by phone, push star 9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, please limit your comments to 3 minutes or less. Amariani, now, could you please open the line for public comment on agenda item number 4, the meeting minutes? Are there any public comments?
I see none.
Okay. So at this time, I would ask that we entertain a motion that the commission approve the August 25th, 2022 commission meeting minutes.
So moved.
Thank you. We have a motion. Do we have a second? Thank you, Commissioner Carnavale. We have a second. Are there any?
Excuse me, who made the motion?
I'm sorry, Commissioner Tamplin did. So I was closed.
Thank you.
Thank you. And Commissioner Carnavale made the second. And are there any questions or comments from my fellow commissioners? Seeing none from the commissioners, Jeff, I would ask that you please take roll.
Thank you, Madam Chair. The motion is to approve the August 25th, 2022 commission meeting minutes. Commissioner Bontrager. Aye. Commissioner Boyd. Commissioner and Sheriff Brown.
Abstain.
Commissioner Bunch.
Aye.
Commissioner Carnavale. Commissioner Assemblymember Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen.
Aye.
Commissioner and Senator Cortese.
Aye.
Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Rolette.
Abstain.
Commissioner Tamplin.
Aye.
Vice Chair Alvarez.
Aye.
Chair Madrigal Weiss.
Aye.
Madam Chair, the motion passes 11 aye, 0 no, 2 abstentions.
Excellent. Thank you. We will now move on to agenda item number 5. The commission will hear an update on the multi-county early psychosis learning healthcare network innovation project. And the update will be on the early psychosis intervention grant program. We will receive information about the successes and challenges of implementing a coordinated specialty care clinic model and consider approval of an early psychosis intervention plus grant program award. We will hear from Charmel Shaw, Chief of Program Operations, Tom Orrick, Chief of Community Engagement and Grants, and Dr. Tara Needham, who is the Executive Director for UC Davis Early Psychosis Programs. I invite you to please go ahead.
Chair, can I interrupt? Sorry. I believe because this requires a vote and LA County is involved, I need to recuse myself.
Thank you, Commissioner Bunch. Please go ahead.
Good morning, Chair Madrigal Weiss, Vice Chair Alvarez, and fellow commissioners. Good morning. Cody, if you could bring the slide up, please. The commission, in partnership with UC Davis Behavioral Health Center of Excellence, has established a collaborative learning healthcare network to improve access to evidence-based and best available care for Californians experiencing psychosis early in the development of their needs. In addition to UC Davis Behavioral Health Center of Excellence, other partners have included One Mind, Stanford University, UC San Francisco, UC San Diego, and the University of Calgary. When we started, less than half of California counties have a dedicated early psychosis program. That is, and existing programs are not currently offering consistent evidence-based care despite the availability of model programs. But this number is changing as we continue the work with these important investments. To move toward the goal of ensuring that all Californians have access to the most effective care, the Commission, through the innovation component, has been working to provide strategic guidance, support technical assistance and training, enhance evaluation to document impact, and disseminate information to create statewide systems improvement. To support these goals, the Commission has supported the development of several multi-county collaboratives. The Early Psychosis Learning Healthcare Network is one of these that supports technical assistance and training, a unified data reporting strategy to ensure fidelity to models of care, and strategies to support sustainable financing of best practices. The collaborative identified 3 primary areas of focus: to provide an infrastructure for an early psychosis learning collaborative across counties where common challenges can be identified. Second, training and technical assistance to support early psychosis program providers so that they have immediate access to relevant client level data that can be quickly shared with partners and counties and state. And then the last focus was the evaluation of the Learning Healthcare Network, which will provide information on how to incorporate measurement-based care into mental health services and demonstrate the impact. As a result of this project, counties will be able to learn from each other and from
Hi, all. I think we lost the feed again. I'm gonna have them pause and we will get it back up. Thanks.
guidance in terms of how we would allocate that $5.5 million. And so what the commission approved was $4 million to support two additional programs. One was for a newer existing program, and that award was provided to Santa Clara County. And then the other was $2 million for a hub and spoke model, which is innovative and necessary for California, just the way our geography is set up in the state. If we're going to provide services, early psychosis services to those around the state, we'll probably need to implement more hub and spoke type models. So that included Nevada County with Colusa County and Mono County as the spokes. So we're excited to see that get launched. And then also with this funding, there was a recommendation and approval of investment of $1 million for public awareness efforts, workforce retention, and then the remainder for research. And so you'll hear more also about the public awareness efforts and workforce development when Dr. Needham speaks. I need to let you know that Santa Barbara County has elected to withdraw from the early psychosis program at this time. They have cited critical staffing shortages that make it very difficult for them to operate this program. And so we've been working with them quite a bit. Their letter is in your packet, just describing briefly that they're dealing with staffing shortages. This is something that we hear a lot about across the state with a lot of our programs.
individuals with first episode psychosis, as well as individuals at clinical high risk, so that we can do measurement-based care. As part of this, we co-developed with clients, families, and providers an early psychosis focused technology platform. I'll show you some images of that today, enabling participation for consumers and families across 13 languages. So we've been collecting data and visualizing that data on recovery-oriented measures that were selected by clients, families, and community partners. And it's built for them to use it in session with those they're working to serve. Then the goal is to be able to have access to all of that outcomes data at a program level and at a state level, so we can very quickly disseminate and improve care. Our evaluation has 3 core components. We've been working, and this is led by Rachel Lowy at UCSF and Todd Gilmer at UCSD, gathering county level data. This is a very direct partnership with our counties where their staff are working collaboratively with us to provide access to the data that, as was mentioned earlier, is in all of these disparate locations, to put it all together so we can look at utilization in terms of outpatient utilization, ED, hospitalization for individuals who are served by early psychosis programs, as well as individuals with similar ages and diagnoses who are not in those programs. So we can see the impact on cost and utilization for these programs. And I'll talk about some of that early data today. I've mentioned the outcomes measures that we have selected in collaboration with our community partners and stakeholders, and that is part of our qualitative data component. We have had over 30 focus groups with almost 200 individuals in both English and Spanish to understand the domains of outcomes that folks care about, as well as show them the measures that we're interested in using and have them guide us on what they think is best. We've had outcomes across other areas that I will discuss as well. But this data was core in informing the program level data component. So these are the detailed outcomes data that we've been collecting through the co-designed platform. We've kind of seen a little bit or heard a little bit about the timeline. Again, we started working with Los Angeles, Orange, Solano, and San Diego counties first, and also received additional funding from OneMind to develop the Learning Healthcare Network. We've had Sonoma, Napa, and Stanislaus join. Kern has been approved and is working to contract with our team. Using this infrastructure, I was able to leverage it towards a very large R01, a research grant from the National Institute for Mental Health, which allowed us to expand further and include 2 more programs in Sacramento.
All right, I apologize everyone for the feed keeps going out and we're not really sure what's going on, but we have a team working on it. If any commissioners online can hear me, if you're able to maybe say something when we do get back up during the discussion, I think that would probably help so that the chair can make a decision on how to move forward with that. Thanks.
the domains that were important. I know this is super tiny on the screens that people are looking at in the room, but if you look in your packet, you can read the words. And what you can see along the left-hand side is the different domains that people were, that we discussed, such as suicide risk, cognition, risk for homelessness, trauma, symptoms, what have you. And along the bottom are the different respondent groups. So clinicians, administrators, prescribers, supervisors, all the way down to consumers and family support persons. So it allows us to see where people agree and where people disagree. And so everybody voted at first. We use that to kind of guide our conversation. And we had a again. And so this sort of shows you the kind of core areas where people agreed. So recovery is one area, and quality of life and well-being were sort of core areas that everybody agreed on. And then functioning was another very important area that people agreed on. Risk for homelessness was not. And as we talked to folks in our groups, it was because many of our folks hadn't experienced homelessness before. And so we were like, that's important because we don't want you to experience homelessness. Yes.
We're having technical difficulties. Okay, so we're going to ask you if you could just pause for a moment. It seems like those in the Zoom world, you're coming in and out.
Okay.
Are you getting that too? Oh, no, I thought maybe you guys were getting text about it. So you're affirming that, yes, that's happening. Yes, you are. Okay, great. So yes, all right. So if we could just ask you to pause. Perfect. We want to make sure that everybody's getting that information. So
Chair, sorry, I realize I recused myself from this, but I know a lot of people are listening.
I did hocus pocus too. What do you guys got? What do you guys got? Let's go together.
Chandra, I'm not sure they can hear you.
Oh, can you hear me?
I can, on the Zoom call.
Oh, well, it looks like we're off again. I was just gonna say, I wonder if they can pause when.
Yeah.
I mean, it seems like people are missing a lot of the presentation.
Yeah, Commissioner Bunch, I let them know, and I think Toby had some thoughts on how to proceed with that, but now I think they're starting to get the message. And so I'm letting them know that we are missing a huge, all these people here on Zoom are missing a huge chunk of the meeting. So I'm going to step away from the computer for a little bit. I'm going to communicate with them.
Okay, thank
some
you.
more. Yeah, sorry about that, Commissioner.
Yeah.
We can see the screen, but we can't hear you.
Yeah, it's all good.
Like, as you feel needing whatever you want to do. Early grade, multiple grades, no grades.
No,
Highly sensitive area. And just.
It's the highest. Right on the
Nice, all right.
Oh my gosh, she's so cute. I know.
Actually, had wisdom people, because it's kind of the age when you live. You're special. We started telling their stuff.
Okay, welcome back, everyone. Thank you so much for your patience with us. We believe that we were able to address the technical difficulties, so we are back. I'm going to have Dr. Tara Needham pick up where she left off. Thank you. So let's go ahead.
Okay, so I've been instructed to focus on the most important points. So forgive me if I kind of skim over some of the slides really quickly. Again, they're available on the website. So if you want to take a look at them, you're welcome to do that. So I am going to finish this slide because I think it's very important how we engaged all of our community partners, clients and families in the work that we're doing. This to me is foundational. So really looking at what they prioritize as what's most important. We certainly brought the science, we brought the research to the table, but we presented it to them and let them make choices. So we see this as being very client and family driven. Additionally, I mentioned that we created an EP focused platform, and we did that again in partnership with those who would be using it. So we had a total of 16 focus groups with 94 participants to co-design the platform that folks are using in care. This is the battery. One of the important pieces of feedback that we got across the board was to reduce burden on clinicians and to increase the voice of the clients and consumers. So there's a lot of self-report on things, again, that they told us were important to them. We also have included self-report from primary support persons, however, whoever is in that individual's life, to understand the supports that they're getting and the other perspectives about what's happening for that individual. And then the clinicians are only providing information on the things that only they have access to. Everything else really comes from the client or consumer. Okay, so I'm going to show you some images in just a second of the dashboard, but the idea here is that we design something that can be given to the consumer or their support person. It's a tablet. We use iPads. They enter their data on these various measures that's ported forward to a provider level dashboard, and again is designed to be used in care with the person who's being served. At the clinic level, that data is summarized. So one of our big pieces of feedback from clinics was we collect all this data, we give it to somebody else, we never get it back, we don't know how to analyze it. So we created a dashboard that allows them to have it at their fingertips. And then at the state level, everything is de-identified, and we can pull all of that data together for reporting when the state or OAC needs it. The clinics aren't bearing that burden anymore. Okay, so this is what the dashboard looks like. So this is one example at a clinic level. This is for my clinic. So I can look in at, these are all of the MHSA reporting demographics that you guys ask for. So this is program duration, just to give you all a sense of how long different folks have been in my program. But you can look, we have race, we have ethnicity, language, disability, veteran status, gender identity, and each of those little cards you can click on and a little image comes up, and program level staff can take a screenshot of that really quickly, put it in a report, put it on slides for their board of directors meeting. It's ready to go. This is an example of data on symptoms. So clients report on their symptoms every 6 months. And so this is a representation from baseline to 128 months for folks who've been in my clinic. And you can see in general, symptoms go down, but this is cross-sectional data. It's not longitudinal. So don't think that it, that 30 whatever months that is that everybody has a relapse. That's not true. That's for those people who just happen to gather. We gathered data at that time point, but it allows, again, you can do this for a clinic or you can do it for an individual and see immediately the data that's available. we didn't find any significant differences in psychiatric inpatient or emergency services. So costs are higher in EP programs than community programs. Utilization is higher. And so we think that the important part of the remaining part of that statement is, okay, well, what do we get for that money? Do we get better outcomes? And again, that is where that statewide harmonized data collection is so important. And we, in this analysis, will be able to link that individual outcome data to the cost data, because the counties are going to link it for us. So we'll be able to say, for this money, we get these outcomes. So again, I have a thank you here, because the counties have worked very hard with us on this part of the analysis. We are also evaluating each of our programs using a fidelity assessment. We're using the FEPS-FS. It was mentioned that we're partnered with the University of Calgary, and that's Don Addington, who developed one of the key fidelity assessment scales for early psychosis care. So we're going to each of them and looking at the kind of services they're providing, and how often they're providing, how consistently they're providing. And then after this evaluation, we give feedback to the programs. These are the areas where you should be looking to invest more, to improve your program, to improve outcomes. So we're using it both for learning and improvement, as well as for the research to understand how access to different components of CSC care leads to better outcomes or worse outcomes. So we're using this in two different ways. I also want to acknowledge that Dr. Mark Saville is working with Dr. Addington on developing a fidelity scale for clinical high risk. We do not have a standard set of practices for serving youth at clinical high risk for psychosis in the United States. So this is something that we're really trying to innovate, since we have not your primary care doctor. This is your cardiologist. This is high need, high intensity acute care service. And so these folks really need training. And when they leave, it's a big loss to the community and the program. So I really do want to highlight one of our challenges we're facing here in the state is workforce development in evidence-based practices. And I do want to also say some of the community-defined practices that have been developed here in the state of California. As Stacy said, there's some amazing practices that have been developed here in California that people should be getting trained in. So I would really love to engage our educational centers, our universities who are training our mental health practitioners, our prescribers, to help them sort of shift toward these practices that we know work. And that's a big lift. So workforce. The other thing I wanted to highlight was high paperwork burden. We're asked to do a lot of paperwork. CalAIM's going to help. Yes, it's going to help. But many local places have very high data reporting requirements and other redundancies, not just for the program, but for their clients. They have an hour of paperwork just for the program that's often county defined. And then we come in and we say, hey, how about we do this 30 minutes of questionnaires? And they're exhausted. I don't blame them. And we have tried to talk with the OAC, talk with these counties about what are the things that we can change or reduce. But there's, again, still a lot of local decisions being made that are implementing these statewide initiatives. So that's something I wanted to sort of lay at your all's feet for consideration. Successes. County staff and programs are working so hard. They are so committed and excited by this project because it was theirs. And we're so proud to support them. This initial investment by the OAC allowed us to get federal dollars and other dollars to grow. And that brings more counties, more programs into our learning healthcare network. I think the other thing I've really heard from our programs in our counties is that this has created a sense of community, a sense of belonging, when many of these programs were feeling sort of isolated and one-offs. And so it's really helped to create community. So our vision, and this has been something that Toby and I have talked a lot about. I've also worked with Brandon Staglin from One Mind on this. Our goal is to bring high quality early psychosis care to all Californians, to everyone who needs it. And so one of our first ways of doing this was the Learning Healthcare Network, where we have 7 counties using innovation dollars, One Mind, feds through NIH, all working together to create harmonized data collection. From this, we then have also been able, with the support of Epi Plus, to create a training and technical assistance center. As we learn things, as we identify problems, how do we then provide training and technical assistance to address them? These things go together. And that's allowed us to support EP program development in 9 counties. So we have gone from 17 programs in 9 counties to now 22 programs across 16 counties. And we're working with DHCS with the hope of expanding this further to 17 more counties for a total of 33. We weren't in this space 5 years ago. We have really made a lot of progress fast because of the support we've received from the OAC, from the counties and the communities that we're working with. So in 2019, our map looked like the one on the left. In 2022, this is what the map looks like. On the right, the different colors are different funding streams, but still that's how many folks are now participating. I want to highlight, and I will highlight this again, our rural, remote, and low population counties are the ones who are not being served. That is a problem. We need to address that. I'll talk a little bit about the multi-county collaborative, but we also, Dr. Stefania Ashby, who's right back here. You have to wave, Stefania. Okay. She has a proposal before the commission that you all will hear more about, hopefully in October, about partnering with our rural and low population counties to understand their needs so that and how we can bring these evidence-based and community-defined practices to them. I've had the pleasure of getting to know some of these communities through the multi-county collaborative. It's a very different world there. We can't use the same approach that we would use in Sacramento or LA or San Francisco in Mono County. It doesn't work. So how do we capitalize on their strengths, of which there are many, to help them build out these programs? And we believe doing that in a very deeply partnered way will allow us to make inroads. All right, so now I'm going to pivot to Epi Plus. So this is our Training and Technical Assistance Center. So we put all of this under EpiCal, the California Early Psychosis Intervention Program. So we have the LHCN and the RO1 off to the right, and then we have our TTA. And in the TTA, the Training and Technical Assistance Center, we have our Epi Plus funded counties, and then we have our mental health block grant funded counties through the Department of Healthcare Services. So we have a contract with DHCS to serve those counties as well. And again, our goal is to help these programs provide high quality care to improve outcomes. So this is, again, the same map, just kind of telling you where we were and where we are now. I want to pause for a second and talk about the multi-county collaborative. So this is something that UC Davis is working with Nevada, Mono, and Colusa County. So we provide the clinical hub services, the core coordinated specialty care services, and we have local hubs in each of these counties that provide those more urgent or immediate services and help to link people to us. We've been up and running since July. We have intakes scheduled. So we are getting referrals. We are seeing clients, myself and Dr. Katie Pierce, who's also here as well. We had the pleasure, along with Dr. Susie Zhang, who's our clinician, to travel to Colusa, Nevada. And we got back from Mono yesterday to go out, see these communities, meet the clinical teams, show them we're real people, we care, hear about what they're doing, what they need, what they want, so that we can be the best partners for them possible. And so we're getting referrals, and we're talking about how do we serve someone in Mono County that's 5 hours away over the mountains in July versus in January, snow versus no snow.
Do they know how frequently we're going offline?
I don't know, Commissioner Bunch. I'll send a text to Lester, Commissioner Bunch. This is Ramona, your recorder.
Of stress that people are under, this is how they're experiencing it. And I think this is an issue for the commission to consider as well. The funding ends at 25 or 30, and I'm getting referrals for 32, 33, and 35-year-olds that I have to say, I'm sorry, I can't serve you. There's nothing worse than telling someone that they're not eligible for service. So I think one of the really wonderful things about this is not just that we're delivering or working to deliver excellent care, but we're also finding the places where we're not, the holes, the gaps, where we could do better. And that is just as important to us as all of the other outcomes and learning that we hope to do. So again, we offer training in all components of this. Jess has been working very hard to set up a learning management system that meets the needs of the folks we are training. We tried to use Canvas. It is not designed for folks in community. So we have now pivoted to a different learning management system. We are going to have a whole bunch of online trainings that people can access easily, as well as in-person consultation, supervision, and support. Really, again, trying to understand the needs of our learners, how to best get information to them quickly, and then support them in the implementation of that. So not everything is going to be live, not everything is didactic, like really trying to have a nice breadth of learning opportunities for folks across this approach to care. Here are all of the trainings we've provided. There are so many, you can barely read them. And all of these were really driven by the requests of the programs that we're serving. So many of these things like compassion fatigue and self-compassion, that was because we heard from our programs, that's what they wanted. So that's what we delivered. So trying to have that balance of disseminating the evidence-based practice, but also meeting the needs of our communities. Here's Cornerstone. This is our new LMS. It's really light and easy. It's something that folks can navigate so much easier. It allows us to do things we weren't able to do before. And then we've been working very hard to develop a number of statewide supports. We have a newsletter. We have created, per the request of our programs, customizable outreach and psychoeducation materials in threshold languages, so they can really quickly put their program logo and name on it and use it. They don't have to think or do much. We have a welcome packet, a training material, our LMS, and a listserv.
So Dr. Needham?
Yeah.
Just for the interest and sake of time, and because there's so much disruption from what's going on, and all the commissioners have the packets and the slides that you were going to share. I'd like to ask you, I'd really like to go into questions from our commissioners regarding the programming, and really, what needs to happen? What's the bottom line? What needs to happen to get care for Californians with that first time early psychosis? What needs to happen?
Well,
and I know that's a huge, but I'm hoping this becomes a conversation with our commissioners.
I think that's great. And I really deeply appreciate the question. I do want to just acknowledge that I do have representatives here from some of the counties that we're working with. And I know I have representation on the line as well. So if they wanted to chime in, I want to make sure that they also have a chance.
I appreciate that. I just think we're losing them. So we're getting that they're not even hearing us.
Okay. Well then,
so,
Aldea, it's all on you. So that's okay. So what do we need? I mean, I think in having these conversations, what has been so amazing about this work with the OAC and the vision that we've been trying to develop is the statewide approach, bringing everyone together to do something at scale. We are able to do so much more as a team compared to individually. So I think that idea is really key. And I'm sorry, I have some of this on the slides. You know, in Sacramento County, I had the capacity to run a high quality program because I was a university and Sacramento County was innovative. But now in working with other counties, you know, sometimes they don't even have contracting staff, or, you know, they can't hire. That was one of the pieces, you know, in speaking with folks in Mono yesterday, hiring high quality clinicians in Mono County is hard. So we're able to leverage things that we wouldn't be able to do otherwise. And so we have this momentum, this amazing momentum toward this collective strategy. And we've just been scaling up. We're able to partner with our universities for the science and for their expertise. We can bring in other funding sources. And, you know, one of the things I've been very excited to do is to partner with the other projects, school mental health. We should be looking at our schools. We should be supporting our schools. These kids and youth are in our schools, or they're not in school and they need to be in school. And how do we get them back to school? Alcove is another really exciting opportunity. So again, I think this much larger collaborative approach, if we look at the other states who've been successful, like Texas, New York, Oregon, this is done at a state level. And thankfully, California, and again, I want to highlight the insight of the OAC is like, we need to do this at a state level. And that's what we're doing. So I think one of the big questions is, how do we keep it going? We have made this investment in TA, in data collection. How do we keep it going? And then how do we leverage it for other questions? When we were in Nevada County meeting their various groups last week, one of the clinicians was like, could we do something like this for eating disorders? Because we can't get eating disorder specialty care here. And I was like, yeah, that makes perfect sense. You could do that. So I think this is just a template, and we're just doing it in early psychosis, but we could do it for trauma disorders. We could do it for eating disorders. We could do it for so many different things. And I have to say, I really look to New York State. They have an amazing Center for Practice Innovations that has allowed them to scale up evidence-based practices. And I would also argue community-defined practices that benefit the communities. How do you get it out there? And asking counties to do it on their own, it's a lot. It's a lot. So I think we need a statewide approach with a consistent vision for how do we take this forward? Because I think the communities want it.
Sure. Thank you. I'll make some comments after, but such important work. My question is, in the education world, I participate in a university-based program around science of reading whose effort is to address workforce issues, to get consistency of best practices and training across the UCs and the CSUs, and to try to take a system view. Is there any mechanism in place like that here, or is that something that we need to explore?
That's something we need to explore. Getting to our the places where our workforce is being built, our colleges, our universities, making sure that they're being taught these evidence-based practices. I want to channel some of my colleagues. We go in and we have to reteach cognitive behavioral therapy. Yeah. Because many people have never been exposed, or they have really bad views of it. We have to reteach those skills before we can ever layer on anything related to psychosis. But once we teach those skills, we can layer on psychosis. I can layer on trauma. I can layer on anxiety disorders and depression. But why aren't they coming out with that foundational knowledge? So yes, I think creating some infrastructure, I would love to be part of that conversation.
Yeah, so I would personally recommend we move to think more about that. And because we keep hearing about workforce development issues across everything that we talk about, and it seems like that could be a point of innovation here. And I would just, the few comments briefly is, the numbers are small, but they're so important because, as you said, this is the tip of the iceberg. What we do here, we can impact across all mental health, and the systemic approach is important. And the only thing that's missing for me, which is my broken record, is that we are dealing with the symptoms, but we're not changing to the trajectory here. And we have the ability now with the current brain research to look at the root causes of these. And this early onset psychosis is the hardest one to study, but it probably has the biggest window of understanding of what creates these problems and how we can begin to intervene early and reduce the problems. And we've got to get thinking about root cause research understanding and not just managing the problems after they've gotten out of control, which is just massive. So I'll stop there. Thank you.
I do want to highlight that the research in the past couple of years has really expanded our understanding of the numbers. So it used to be we would talk about 1 to 2% of the population. It is much higher than that. So incidence rates, when we look across commercial insurance and Medi-Cal, because the rates are different, we see that in California, we should be expecting 27,000 new cases of psychosis per year. In Sacramento County alone, that's 1,000 individuals with psychosis. My program's set up for 1/10 of that. So it is a much, and then if you look at clinical high risk, we're going to multiply that number times 3. So that's 100,000 people per year who are needing our services. That's a lot of people. And those are the people who aren't in school, therefore don't graduate, struggle to get a job. Their first contact with mental health is through the police, end up on our streets. So
And cost the system a fortune on top of being a human tragedy.
$45,000 a year.
Yeah, that we can, the ROI of early intervention is massive.
Yeah. And I really appreciate your comments about brain and those things, but I also really want to amplify how trauma and systemic racism are also causal factors in psychosis. And so important for us to address those issues as well. And so we take that again incredibly seriously in the work that we're doing to reduce the impact of these illnesses and ensure that everyone has access to excellent care. Thank you. Commissioner Chambers, please.
I'll keep it real short. I just want to commend your work. I do wanted to piggyback off Commissioner Carnival relative to workforce development and just highlight burnout because we do train young aspiring clinicians at Painted Brain, which I'm the co-executive director of. I do recognize that there is, issues with training as well, and though burnout. So if we did do some kind of innovation, I like it to focus on, that training early on in those evidence-based practices, and then how do we as a system create whole and healthy environments for the clinicians that are on the front line addressing one of the most complex mental health challenge that we know of in the world. And as someone that experienced psychosis at the early onset at 14, I know that this service is like critical because it is impact, and trauma was the reason why, and systemic racism, but trauma was the reason why the onset happened for me. So I just want to commend the work and let you know that there are people on the ground that's invested, and just really appreciate your work. Thank you.
Thank you so much. I do want to highlight that One Mind has been working with us to develop an approach to addressing workforce. They have a One Mind at Work program, and we are hoping to partner with them to go into each of our programs and understand what is driving burnout because what we see is it's different across the different staffing levels, from a clinician to a peer to a prescriber. And so what do each of them need to feel good in that workspace so that they can stay with us? Especially if you've got a peer with lived experience with psychosis in our workforce, oh, they are like purple sparkly unicorns. We want to keep them there because that lived experience is so valuable to the folks, the families they're working with, the clients they're working with. So we want to figure out how to best support them. And One Mind is really working with us on that.
I think that's a challenge in the system overall, to just make sure that peers are in leadership roles, and that our experience is just as good as the other multidisciplinary clinician or other person on the clinical team, and that we aren't tokenized for our experience, and that the workplace is set up for individuals of all abilities, including individuals with psychiatric disabilities. So just wanted, every chance I get, I want to make sure that we utilize peers in the appropriate manner, and at our agency, peers are leaders in the multidisciplinary team. And I like how you had that up on your PowerPoint, the peer being integrated into the system. You did use the word leadership. Just knowing that peers are leaders, our lived experience probably is just as good as like a medication management doctor, because we know almost every pill, and we know what the symptoms are, and we probably can break it down better than other people. So just want to highlight that
Thank
you did have that as well.
Hi, Dr. Needham, how are you?
I'm good. How are you?
Doing well. Full disclosure, I'm familiar with Dr. Needham's work and the UC Davis Early Psychosis Program. I've visited the Mind Institute many times, and so I'm a champion. And so I need to say that in the beginning. My other part of my preamble is I also appreciate your emphasis on the social determinants that was inculcated throughout your presentation. Your reference to systemic racism and how it impacts people along their journey. And then in terms of early psychosis and intervention, and I can't remember who always says this, but I just want to point out, you talked about, and here's how I appreciate it, a data platform that is shared across all participants. And we really need that, because you know this, that the data informs service delivery, or at least it should. And if you can't access data, or as you referenced in your metaphor, if data goes into a black hole and we can't get it back in a meaningful way, it doesn't inform anything. And so that part of what you are doing in your work really does, in my mind, provide a template for how behavioral health services should be delivered in other areas. And so I applaud you on that, and I applaud your continuation of that part of the effort. Again, I would be duplicating things that have already been said, but I am a champion of early psychosis and intervention, early psychosis intervention. And then the last point is that as we work through the workforce challenges that are affecting us all, and here's my attempt at some humor, Chair. I didn't know what ghosting was until I started recruiting people. And then I realized, oh, that's what that is. You don't show up. Well, therein lies the unique challenge. And we've got to figure out a way to not only get representation in your clinic, but in every area of behavioral health. Because this notion of the clinical shortage, we've already identified that. It can't be an excuse to preventing quality care. And so we've got to advance other strategies, other community-defined strategies that will make a difference and impact the lives of the people that we're privileged to work with. So thank you very much.
Thank you.
Thank you. Thank you for your presentation. I have a comment and sort of a question, and then one very specific question. One is, I really appreciated, building on Commissioner Roulette's comments, your not only the emphasis on the social drivers of health, but also your connection to integrating community-defined practices. Because we hear a lot about the leadership of community and moving forward community-defined practices and finding ways to really institutionalize these practices so that they're not special programs or set aside, but that they're baked into how our systems are better meeting the needs of our diverse communities across the state. So I wanted to pause on that because we don't hear that a lot from our standard programs that OAC funds, or that the MHSA funds, right? And you all are baking it into the system so that it's set up better to serve the needs of our communities. And I think that is chipping away at the systemic racism that we know our programs and systems have had in place for far too long. So thank you for that leadership, and I'm excited for us to learn more about how you're doing that, so all of those funding streams can reflect this commitment. So that was one. And then my question is this idea of streamlining data collection. Also, we hear about that so much, and the frustration from counties, but also the frustration from providers themselves. I'm curious, how does that system interact or connect with the EMR? And does it?
Oh, okay. So one of the challenges of connecting to an EMR is that your level of security for any application has to be so high. So, and then also here in California, pre-Cal AIM, we have multiple EMRs, even within a county. So that means our application has to build a back end into all of those EMRs. The level, like the lift of that is massive. So again, Cal AIM's going to streamline that because certainly all of our providers would love to have these images just show up there. But I think it's also important in working with providers in this realm of health technology, what do they want to see there? Because it might not be what I think should be there. And so you also have to do partnered work to understand what's going to be most useful for them in the EMR. So the reason why we didn't build them to talk to each other is because of all of this. And I don't know about y'all, if you've spent time in EMRs, I get to spend time in EMRs. They are not built for clients to look at or family members to look at. And that was a primary goal, is because we heard from our providers, I got to bill for this time. If you're having me do this, it's got to be billable. So we built it so that it can be reviewed in real time with the folks that they're serving. And so we built something that they wanted to look at, not that QA wants to look at. So I think there's some challenges here on the goals of how we build these. They're designed for different things, and then how we integrate them. So if you were to ask me my long-term vision, it would be great if we built an EMR that actually you could sit with a client and do your note and not worry about the other things on the screen because they were comfortable being in that platform with you. That's not how they're designed. So we've got a number of different things we're trying to do there. It is challenging to ask providers. My providers at EDAPT have 2 medical records, and then they're in Beehive as well. So they have 3 screens up at any given time. They don't like me very much because of that. But if, we have other contracts with other counties. And so if they say, I need you to use my version of Avatar or my version of Anasazi, then they have 4 screens, 5 screens, depending on the client in the room. And so that's, I think, the thing that gets lost sometimes at this higher level of how allowing everybody to make their own choices, what that means for the people in the room doing the work is a lot. And so they burn out, or they don't feel comfortable working in this. It's a very tech heavy space. And so they leave. It doesn't feel like it's made for them. I see this a lot for my peers. So, I think this is part of in that qualitative work that we're doing with all of our community partners, is really trying to understand what their needs are, what their goals are for the data, and how do we build something to meet those needs, while also understanding the needs of the payers or the OAC or the state, and how do we do something to meet those needs? Because sometimes we're best poised to do all of those things, and it takes so much burden off of the providers in the counties. Any other commissioners like to make a statement or question? Because I have some, so I'm just holding back. So if I could, I'm sorry, I didn't see anybody else.
So I'm so excited about all of this, and I'm trying to take, so this is how I take notes. It's, yeah, didn't get good grades in writing, but let me say this. Thank you so much for presenting today. And I'm so hopeful, and I'm hearing things, Vice Chair Alvarez and I are both on the PEI subcommittee, and we've been learning a lot throughout this process. And based on what Commissioner Rolette said, the systemic racism, and there's a couple things that I heard. The statewide approach, a leadership team, the statewide approach, love that, but something that we're calling out as well. And also the community defined practices. That's something that we've heard loudly from the community saying, it has to relate and it has to be meaningful. And so what does that look like? And so I think there's more to learn on the system side. Community knows exactly, but on the system side, and how do we really bring that forth? And so I think that's important. A system where we have common definitions so we can create measurements is so exciting to me. We have it in the criminal systems. We have that down pat. We have it in the medical systems. We have that down pat. And why not in the mental health system? So I'm, it's, you're getting us closer there. And I thank you for that. We're going to be doing the screening on hiding in plain sight. And as I watched that last night, the students, the youth, were talking about everything that impacts their mental health. Systemic racism, trauma, anxiety, manic depression. If we create the statewide system where we have those common definitions, where we're able to identify and track and measure all those things, then we're doing the right thing. So you're taking those first steps. So I thank you. I'm so proud of the work that we're all doing, that you're teaching us. So I just want to say that. And I kept it together. So thank you for your time. If there are no other questions or comments, please, Commissioner Bontrager.
I'll make a quick comment. First of all, I just a couple comments, then actually one question. And that is, I'm familiar with the EDAP program, and I think it's a prime example of where a robust set of services that are well-resourced can actually move the needle, which is kind of a novel idea in mental health land. We focus a lot on more and faster. We need more services, we need them faster, but rarely do we talk about better. And I think in this scenario, it's both fast, it's better, faster, and it's more, and it does move the needle. So I'm a big fan of this, proponent of it. I think the idea of proof of concept matters because we could apply this in several other vantage points in mental health. The question I have then for you is has there been any discussion with this new statewide virtual platform, the near $1 billion that the state is spending? There's an e-consult component to that. Has there been any discussion with your group, inclusion of your group?
Thanks. That's, yes, an area that we have thought about. So we created this hub and spoke approach as one way of providing service to someone who's not local. Another way of doing that is through e-consult. We could, consult with someone, a clinician, a prescriber, whatever it may be, right, in a remote area or even a local area. We've talked about being able to do that to provide direct clinical service. So one of the biggest challenges we have is the assessments that we do are incredibly thorough, about 4 hours long. And to really understand what's driving the symptoms that we're seeing in the youth. And so some of our counties have said, we can stand up the peer, the case management, the clinician, the prescriber, but this assessment lift is so heavy. Can you provide that? So that's a direct billable service, not just a consult. So we're talking about all of these different things to meet the local need, depending on the resources that the local sites have. But yeah, that's one of the things we're talking about, again, to build up service.
Okay, any other questions or comments from commissioners? See none. Thank you for your presentations. Thank you so much, Dr.
Thank you.
Needham, for your
Really
team for
appreciate
coming
your
with
all's
you.
time.
Thank you. At this time, I'm going to ask Tom if you could come back up to the table and present the options available to allocate available funds for the early psychosis grant program.
Okay, great. Thank you, Chairman Weiss. I don't know if Cody, we can get the slide back up, but yeah, I'm just coming up to finish the final piece of this agenda item, which is to allocate the funds that have been returned from Santa Barbara County. And so we have some options with that, much like with the Immigrant and Refugee Awards. Last month, you may remember, we were able to quickly pivot when additional funds were provided and award to the next highest scoring applicants in the procurement. And so we can do that because in the request for application, we state that if additional funds become available, we can then assign those to the next highest scoring applicant. And so with Santa Barbara's funding, we're able to do that in this case. And so what we would do is to one of two options, to either augment the return funds with retained or unallocated EPI Plus funds and award a $2 million contract grant to the next highest scoring applicant. Or we could release a new RFA entirely. There are some pros and cons listed in your packet about that. But basically the recommended option is option A, which would be to award to the next highest scoring applicant. This saves us several months in terms of getting funds out to support these programs. That's the downside of releasing a new RFA. The upside is we can keep the same number of awardees in this program and get these funds out more quickly. And so the recommended option is option A. And if the commission approved that, well, there's option B. The proposed motion would be that the commission award a contract of $2 million to the next highest scoring applicant from the EPI Plus RFA 2 grant program.
Questions regarding what Tom just presented? Please.
You might have mentioned this, but were there other counties that were interested in joining that
Yes.
didn't apply?
Yeah, no, I didn't mention that. There were in our first round, the RFA, the first RFA, we only had 5 applicants. And so the second RFA had 8 applicants, I believe. So we awarded 2 grants. So there were applicants there were counties that applied that were not awarded. And so that's where we would draw from for the next highest applicant. So yes, there were several counties who applied. And in terms of other counties other than that who might be interested, I think Dr. Needham might be better to answer that. She's probably more connected to different counties around the state who are interested. But
wouldn't that be important to know to make a vote, or am I the only one?
no, I think that's what the there. Oh, great. You can help there. That's why we're presenting. Yeah. Go ahead.
So I do want to say that many of those other counties are going to be getting support through the DHCS contract that we have. So it's a lot of counties that are coming in with those additional funds. So I defer to you. I just wanted you to know that many other counties with other programs are going to be getting TA support as well through the DHCS funds.
I'm a little confused. So we don't need this money then? Is that what?
Oh, I'm not saying that.
So let me
I'm just
kinda what I'm
saying
hearing.
that there's a lot of counties that are getting support too.
Let me
So
clarify a couple of items, okay? So what Tom is saying is the commission issued a request for proposals, and there were 8 applicants. We funded 2, and subsequently one of them dropped out. And so the option you have in front of you is to simply award the remaining funds to the next candidate in line. If, however, so the pros of that is that it's quick, it's fair, right? And the other alternative is we step back, we do a whole new procurement. It'll take 6 to 9 months, and that would address the instance of counties that chose not to apply the first round or that wanted to revise their proposal and perhaps score higher. And so Commissioner Chambers is saying, well, what about those counties that did not apply initially? And yes, that may be the case. What Dr. Needham is pointing out is that there are multiple sources of funds that counties can use to participate in this project. First, the original counties that participated in this project did so using MHSA innovation funds. The actual first 15 million or so, maybe didn't get the number right, was funded with county MHSA dollars. So counties that are interested that do not prevail in accessing the state funds can use local dollars. Second, the federal government provides a block grant to the state of California through SAMHSA, and there's a mandatory set aside of those funds to be used for early psychosis. And so counties actually are required to use their federal block grant share allocation, and there are funds coming through the state through DHCS that are available. So it's not that these dollars aren't important, but it is that there are multiple paths for those counties that may be interested in participating in the project that don't prevail with the funds that the commission is, has in the bank at the moment for this purpose. The only reason we're here is because a county received a grant and then stepped back and said, we're not in a position to do this. So if you are concerned about opening it up so that everybody could participate who might want to participate, then the choice is option B, which is to go back to the drawing board and create a level playing field again. If the focus is on speed and efficiency in terms of releasing dollars, then option A. And I think what you're hearing from staff is option A is probably the better choice because of the other dollars that are available through the state or through local sources for those counties that are not successful. But that's the way this item was identified for your consideration, and we can certainly revisit that.
Commissioner Brown, please.
Yes, given the limited amount of money that's available, and also given the fact that the other initial applicants were told that there might be, if money came back, that money would be available for them as well. And given the fact that because it would take 6 to 9 months to get this out and only have a limited amount of money, I think it would be more prudent for us to move. And I would move now for the staff recommendation.
I would second that motion.
Itai. Commissioner Danovich seconds the motion.
I have a clarifying question. I just want to make sure I understand what Commissioner Brown asserted, that there was a provision in the RFA that said if there were funds that were returned or not utilized, that other applicants might be considered, or I even assume that the awarded applicant might get additional dollars. Is that correct?
Yeah, no, it states that the funds would go to the next highest scoring applicant who didn't receive funds.
That answers my question.
Any other comments or questions? So we have a motion by Commissioner Brown and a second by Commissioner Danovich.
I have one quick question or comment.
Please.
And this just speaks to the reason why Santa Barbara County backed out. That's really troubling. The staff shortage area or critical staff shortage, and I'm sure that I know that's happening across the county. But to Commissioner Brauntrigger's question about e-consult, like, isn't that the purpose of e-consult, right? To be able to leverage resources from across the state, across the country, to bring in where there are critical staffing shortages. I don't think we have an answer right now. I would love as a commission to learn more about those critical staffing shortages and where there may be opportunities to help fill gaps.
Absolutely. Thank you.
And my sense
Thank
was that it wasn't necessarily only in clinical staff, but also administration and behavioral health leadership.
Yeah.
So it might be staff, critical staffing shortages across the system there.
And I can just add to that is exactly the case, and that we have same concerns with our co-response program and with other programs in the county that are specialized programs that call for some non-traditional approaches, scheduling or what have you. And it's, unfortunately, this is a problem that we're dealing with in law enforcement, and we're seeing it across the board. It's just hard to find qualified people that want to take these positions. And so I know that they're struggling, and it pains me to see the money leave Santa Barbara, but I think that it would be the most expeditious route to get it to working for the good would be to get it back out there as quickly as possible.
Agreed. Thank you, commissioners. At this time, we are going to move to public comment. So members of the public may request to make a public comment on agenda item number 5 by clicking the raise hand button on your computer or app by pressing *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. At this time, just for the sake of time, we're at 11:38. I am going to ask you to limit your comments to 2 minutes, please. Amirani, please open the line for public comment on agenda item number 5.
Okay, the first comment is Anna. Your line is open. You may go ahead.
Thank you. Thank you for this presentation. This is an amazing opportunity. I want to make a couple of points. Even during the presentation, I heard a lot of medical model language, even though we are talking about recovery and trying to involve community and folks who's going to receive those services. I'm hearing the language client, consumer centered, not consumer driven. There is a big difference in that. And I can see again in the presentation and the way this project has been designed, I didn't hear that consumers, peers, peer support specialists and advocates were part of designing this program. I urge you to look at that. I urge you to include those folks, those of us in the process, get us to the table as we're creating those programs, because this is the most, in my experience, sharing power is one of the most powerful wellness tools. If you really want to help community and to help us, do that. It will not cost us a lot more. We're still very cheap labor. And it doesn't mean, that the whole program should be done by consumers. No, I'm talking about partnership, equal partnership. And at the beginning of this session today, you honored Sally Zinman, and I heard folks talking about nothing about us without us. Please adhere to those principles. It's very important. Thank you so much.
Thank you, Anna.
Next, we have Teresa. Your line is open. You may go ahead.
Hi, I'm Teresa Comstock with California Association of Local Behavioral Health Boards and Commissions, supporting the work of California's 59 mental and behavioral health boards and commissions, as well as I'm the chair of the State Rehabilitation Council that advises California's Department of Rehabilitation. I wanted to emphasize the importance of integrating vocational services with mental health services for individuals experiencing early psychosis. Work helps us feel well. Employment is a major therapeutic tool. California's Department of Rehabilitation provides education and employment services to people with disabilities, many of whom are in high school. Some mental health agencies offer integrated vocational services for youth and adults, but it would be good for all communities to offer these vocational services as a key component in early psychosis programs, whether it is provided by local behavioral health agency staff, contractors, and or through cooperatives with local Department of Rehabilitation staff or contractors. It's an essential piece. Thank you.
Thank you, Teresa.
Next, we have call-in user 5. Your line is open. You may go ahead.
Hi, this is Mark Carmat. I wonder if the presenter. Hi, this is Mark Carmat. I wonder if the presenter. has learned about the quality assessment common ingredients tool, which was developed by Miss Jean Campbell out of the University of Missouri and also out of University of Illinois.
Please go ahead, Mark.
It's called as far as I remember, it's called the Quality Assessment Common Ingredients Tool. And we learned about it at Alternatives. I did 2005 in Nevada. No, so I was thinking possibly that's something that you might want to take a look at.
Thank you, Mark.
Those were our last virtual comments, and then we have 2 in-room comments as well.
Thank you, please.
Julie Burns.
Hi, my name is actually Carrie Ahern. I'm the CEO at Aldea. We're the essential community partners for children, youth, young adults, and families. We have early psychosis programs in Solano County, Napa County, and Sonoma County. And we want to say thank you to the commission. We have much support from you all. We do the Learning Healthcare Network in all 3 of the counties. We also receive some EpiPlus funding in Sonoma County. And I'd like to comment on, yes, there's definitely a workforce crisis. And I hear that when the EpiPlus funds first came out, Napa and Solano counties were saying that they just don't have the bandwidth to even, administratively get those funds. So that's an issue. And also for nonprofit providers like us, we would like more access to some of those dollars because we have EpiPluses, we're able to leverage so many funding sources, but to have the bandwidth to, manage the multiple funding sources, it can be administratively burdensome. But we want to thank you, and we are just honored and privileged to work with Tara and her team. They are wonderful, and the way they've pulled in counties to support these programs is just amazing. So thank you all.
Thank you, Julie. Carrie, sorry, I apologize.
Good morning. We switched it up. My name is Julie Burns. I'm the Chief Program Officer for Aldea. And I really heard such great comments from the commission. Rarely have I stood before a group of individuals where I didn't have to make a case that this work is important. So I must say that that is something I just have to express a lot of gratitude for. I'd also just like to compliment UC Davis and specifically Dr. Needham. Not only are they leading cutting edge advances in early psychosis, but they are credible, ethical, and really responsible stewards of the resources that are available to us. And so again, I just want to express how impressed I am by that. In terms of the impact of statewide leadership and the collaborative, prior to my work here, I spent over a decade working specifically as a mental health provider and in management in juvenile detention facilities, in jail and law enforcement settings. And oftentimes as a provider, we are committed to the work. This was the first time I actually saw psychosis myself. Not something I read in a book in my master's program, but actually showing up in the jail and assessing somebody who's on suicide watch. And to fight upstream in that work for so long obviously facilitates a lot of burnout. So to be able to do this work proactively, to do it with a more prevention-minded and education mindset, this is something that works. We are not reinventing the wheel. We are getting smarter and more efficient with how the wheel works. Having been a leader of many grant projects, SAMHSA funds, there's nothing more discouraging than finally getting it to work and then losing that funding. So I just, again, want to commend everybody involved in this project for really prioritizing efficiency and resources and for being devoted to things that work for consumers. Us and our staff are the ones who are actually meeting with the consumers, with their families. So Dr. Needham makes it all sound very easy and very, very simplified, but really being in the weeds with families and seeing those outcomes and seeing those changes and tending to the workforce, as my supervisor mentioned, we need to be able to sustain the people who are devoted to this work. So thank you very much.
Thank you.
That was our final public comment.
Thank you, Mariani. Now that public comments have closed, I would entertain are there any other questions or comments from my fellow commissioners?
I did have a quick question, or
Please.
Chair Madrigal-Weiss, around what Anna brought up, the nothing about us without us involvement of the consumers. If Dr. Needham can mention that again, the involvement. I know you talked about One Mind, but are there other peer-run organizations that are working in our communities, especially public mental health communities that are involved?
Yeah, thank you for bringing that up because I heard that and I was like, oh, yes, this is so important. So I appreciate the opportunity to address that. I would say that one of the things that we have done, and again, I want to point to Dr. Hayes, in trying to engage local communities is some of them don't really have much of a psychosis focus. And so we think that that's also a really important piece of the voice that we want to amplify. So one of the ways in which we're investing our dollars is to create a group of advisors who are paid for their time at a good wage to help us create more opportunities for folks with lived experience with psychosis to be part. And so we will be reaching out again to many of our peer organizations to see if they have folks who would like to join. And then we're also going to be working to create a family and kind of support person group, advisory group as well, to make sure we're hearing that piece too. And those, again, in our organization are centered within the leadership team.
Great. And are you'll prioritize communities of color, especially since you talked about?
Oh, yes. Oh, yes. We,
that's
so I apologize. My two DEIA leaders, one is seeing clients and the other is not local anymore. And so bringing those pieces in and making sure, again, that across all of the work that we're doing, that those voices and those needs are centered. I think one of the things we have to recognize, though, is with the diversity here in California, having representation from all of those communities is challenging. So again, we're looking to the communities we work with to help us identify folks who can work with us and help to bring forward those concerns. And we will be paying those folks for their time collaborating with us.
And I think, you know, both Commissioner Chambers and I are chair and vice chair of the Client and Family Leadership Committee. So we'd be happy to help you in recruiting folks.
Thank you. I really appreciate that.
Thank you, Commissioner Tamplin. All right, no other questions or comments. We have a motion and a second to approve that the commission award a contract of $2 million to the next highest scoring applicant from the EPI Plus. No other questions or comments. I already said that. I'm sorry. At this time, Jeff, I will ask you to take a roll on the motion and announce. Take a roll on the motion, please.
Motion to award a contract of $2 million to the next highest scoring applicant. Commissioner Bontrager.
Aye.
Commissioner Boyd. Commissioner Brown.
Aye.
Commissioner Bunch.
Abstain.
Commissioner Carnavale.
Yes.
Commissioner Carrillo. Commissioner Chambers.
Abstain.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Rolette.
Yes.
Commissioner Tamplin.
Aye.
Vice Chair Alvarez.
Aye.
Chair Madrigal-Weiss.
Aye.
Madam Chair, the motion passes 9 aye, 0 no, and 2 abstentions.
Thank you, Jeff. Thank you so much for being here today. Applaud your work. Next, we will move to agenda item number 6, and the commission will hear an update on recent adjustments made to Mental Health Wellness Act, Senate Bill 82, and consider approving funding for the Empath Emergency Psychiatry Program and provide guidance on the priorities for future funding opportunities. We will be hearing from Executive Director Toby Ewing.
Thank you, Madam Chair and Commissioners. Really appreciate your time today and recognize that we faced some delays, and so I'm going to try to be very efficient in terms of time. Really, I want to just remind you of the conversations we had late last year and then earlier this year around the Mental Health Wellness Act. And then there's a proposed motion in the packet in terms of allocating some of those funds, and then hopefully a discussion about some remaining funds. You may recall that I believe it was in October, we heard presentations from the County Behavioral Health Directors Association on some of the challenges with the structure of the Mental Health Wellness Act. When the act was first passed in 2012 or 2013, it prioritized using state dollars to provide supplemental funding to counties to hire staff to be responsive to mental health crises. At that time, the funding was $32 million. Today, it's $20 million. This is annually. The budget was reduced by $12 million because the counties were only able to spend about 2/3 of those funds over the course of the grant allocation. That was primarily because of difficulty using these funds to hire personnel. Short-term personnel financing can be very difficult, and so counties ended up returning large amounts of those dollars. We also heard many concerns that the funds were prioritized for crisis services rather than crisis prevention and early intervention. And so in discussions with you, your direction was to work with the governor and the legislature to modify the provisions of the Mental Health Wellness Act to be more comprehensive and more flexible in focusing on crisis prevention, early intervention, in addition to response. Recognizing that the crisis prevention, early intervention work can be performed by lots of community partners, where the original language of the law required the commission to enter into a competitive procurement only with counties. The legislation was modified to allow these funds to go to a broader array of community partners who can be instrumental in terms of prevention, early intervention, in addition to crisis. So these funds are available to counties, but not only counties. They're also available for personnel needs, but not only for personnel needs, also because of the challenges in staffing, but recognizing that sometimes these funds can be best made available for demonstration projects, research, outreach, engagement, capacity building, lots of ways to use them. There were 2 other changes to the law. Because the requirement was that these were supplemental funds for counties, the commission was not allowed to require a match. But because the opportunities to use these funds was opened up, the commission now can require a match. The original law also required these funds to be allocated through a competitive procurement. We argued that for small counties, for very small counties, for small community-based organizations and other potential recipients, competitive procurement can be very difficult. And we saw, actually we saw in the Mental Health Student Services Act that many of the smallest counties wouldn't even apply because they didn't have the staff to apply. So the commission provided, the legislature and the governor provided the commission with the authority to use these funds in limited instances in a non-competitive procurement when it's consistent with the intent of the act, or there's a very clear public benefit to doing so. So the commissions, the $20 million that you have in your budget every year, we held off in allocating those funds last year because we were in the middle of securing this flexibility in terms of SB 82. But at that time, we heard a presentation from Dr. Scott Zeller about a hospital-based crisis stabilization program called Empath. We organized a site visit to Southern California, to a program down there. We organized a site visit to a program in Sacramento County that was funded with innovation funds. And the commission expressed significant interest in supporting the expansion of this strategy. The Empath program, you may recall, it was designed to reduce the number of mental health consumers who go into an emergency department either under an involuntary hold like a 5150 or voluntarily, who often are kept in the hallway waiting for a transfer to a either a psych hospital or to another community-based crisis stabilization unit. The argument for a hospital-based system was that they could both manage the physical health needs and provide peer support and crisis stabilization support on site. Nationally, the research suggests that the instance of bed boarding is decreased dramatically. Transfers to psych hospitals go down. The programs accelerate access to community-based programs once the person is stabilized in that emergency department setting. So given the interest from the commission at that time, staff has put together a proposal, if you're interested, in providing some of the Mental Health Wellness Act funds through a competitive grant program to support the expansion of these empath units. Specifically, we'd suggested that of the $20 million that you have per year, it's funding from last fiscal year and this fiscal year. We'd recommend at most you would use 4 years of funding, so next fiscal year and the following fiscal year. So there's a pool of potentially $80 million available for the next round of Mental Health Wellness Act grants. Staff would recommend setting aside, we're recommending $20 million of those funds for empath if you're so inclined, with $17 million for grants that would go towards program development and $3 million set aside for technical assistance and evaluation. And we would do the $17 million through a competitive procurement process, the smaller amount, the $3 million, to a non-competitive procurement process, specifically because we need to actually sit down with the folks who are most familiar with this program to make sure that we have the right kind of capacity building support. It's a relatively specialized program. And so in the interest of making sure that we're hiring the experts who can do the best job in terms of the technical assistance, that we would want that $3 million to be more flexibly allocated through a non-competitive procurement. It's also a relatively small amount of money. Let me just stop there. Any questions about the flexibility around SB 82 that you have, the $20 million, the idea of allocating that over 4 years worth of that money for $80 million?
Can you help me? I do have a question.
Yeah.
So you said 20 million for Empath? And that's over how many years?
So currently the state's rules require us to use these dollars within a certain time frame. Because we didn't use last year's dollars, that time frame for last year's dollars would only give us 2 additional years unless we seek some additional authority from the legislature, which we plan to do, so that what we would propose would be a 3 to 5 year window. But we need to get some support. We need to modify the fiscal arrangement that we're under at the moment, depending on how you may want to use the balance of those funds.
And was it within that 20 million, 17 of it is competitive and 3 million is the non-competitive?
That's the staff's
TA.
recommendation in order to
okay.
make sure that there's high fidelity to the model. And we would work with the Commissioner Danovich and the Research and Evaluation Advisory Committee to make sure that we build the evaluation in at the beginning of the project. And so that's part of the reason for wanting to do this non-competitively, is so that we can actually work with those folks to help design the competitive piece.
And so is it okay if I ask another question, Chair? And so the proposal is to focus on empath? Because I know the legislation changed and added, support crisis prevention and early intervention. Are you proposing that specific program? Because I was also hoping, peer respites could find some, we can get more of those up and running. Is that possible in this right now?
So the pool of funds that we recommend that you think about having is $80 million. And so the $20 million that we're putting in front of you is a direct response to the presentation that we received last year and the interest in the site visits. Peers are involved in the empath programs, but that doesn't mean that some of the other money could not be dedicated specifically to more peer-centric strategies.
Like peer respites?
Like peer respites.
Thank you.
Other questions? Yes, please.
Okay. To that point, Toby, those discussions on the 60 million over the next few years, how do we discuss that as a commission in the spirit of transparency, in the spirit of the crisis that many know about? Like, talk to us about that.
Yes, thank you. So that is the third part of my presentation on this item. That's okay. It's good timing. I just want to make sure that I had laid the groundwork in terms of the flexibility that you have and the $80 million that you have. Last year, when we came to you with this very question, there were three issues that were highlighted. One was to recognize the number of consumers who are take themselves in or are taken into emergency departments and sort of get stuck there, often for 5 days or a week. They may or may not be transitioned out into an appropriate service. They may just go home after that. So we organized a presentation from Dr. Zeller on this particular project because it was specific to one of the issues that the commission had raised about strengthening ways in which we can make sure that our emergency departments are actually part of a positive continuum of care rather than a place where people get taken and sort of get stuck, right? The second two themes that the commission highlighted were to focus on 0 to 5 and to focus on older adults. You may recall we had Dr. Jackie Wong, the executive director of the First 5 Commission, come and talk about some of the needs of the 0 to 5 population. We did not, however, develop a specific programmatic proposal following that conversation. In other words, we didn't get guidance from you or the presentation on what specifically to invest in should the commission want to invest some of the SB 82 dollars in the 0 to 5 population. And so one of the things we're asking you today is if you do want us to invest some of those funds, if you want to invest some of those funds in the 0 to 5 population, that we would want to do the homework and actually identify a specific project to invest in rather than this general. On the older adults issue, which is something that the commission had spoken of for several years, I recall this greatly because I made this comment that I too someday hope to be an older adult, and one of you said, "You're already there, Toby." So that was you, Commissioner Gordon. I appreciate you saying that. So we had tried to arrange a presentation from the then director of the Department of Aging, but she was transitioning to the governor's office. We were able to meet with the new director of the Department of Aging and participate in a statewide conference earlier this week around the state's master plan on aging, and they have explicitly said that they want to strengthen their capacity to address the behavioral health needs of older Californians as part of their effort to support Californians of all ages. And simultaneously, we want to enhance our capacity to understand what the greatest needs are and what is effective in terms of the older adult community. And the aging director has offered to work with us to develop a proposal for you to consider on the needs of older adults if that continues to be a priority. Clearly, peer respite, Commissioner Danovich has over the past few years raised the issue of addiction, right? Access to drug treatment. We certainly see that profound need in the conversations that are happening around homeless encampments in California, around suicide, around other high priority risks. So this is an opportunity, Madam Vice Chair, to talk about priorities and to give staff direction. If you choose to move with the empath, right, that would dedicate $20 million. It could be less, it could be more. And then there would be 60 million remaining for investment. And so we're hoping to have those two conversations with you today.
May I make a comment? I don't know if you could hear me. This is Commissioner
Danovich, we can hear you, please.
Okay, great. Thank you. A couple things. First, just to echo what Toby just said, I do think that it is important that we find an opportunity to address substance use disorders. Substance use disorders impact all of our populations, the young, the old, the middle, and with all the other concerns that we have. And it's an area where we haven't had sufficient attention and haven't had enough impact. But I want to address specifically first this empath piece. I think there's a little bit of a thematic similarity between the empath model and the early psychosis program that we heard about, and that these are empirically supported models of care that address critical issues among people who are at risk for serious mental health problems. And empath units are like a form of secondary prevention because it's taking something that's already become a problem and trying to prevent it from becoming worse. And it also links to a goal that we have to reduce hospitalizations and facilitate appropriate and effective treatment in the community. So I'm really supportive of, and I would make a motion in support of the motion that's on the table to fund this initiative for empath, because it links to a goal that we have on reducing hospitalization, and it supports an empirically supported model of care, this empath unit, to be able to do it. And that increases for us the likelihood that this model of care actually does do what it purports to do, that it actually will achieve the aims that we want. And as we talk about the 60 million, the other funds, I just hope that whatever it is we talk about, we think in terms of the high level goals that we're trying to achieve, reducing, access to care, improving access to care, reducing hospitalizations, reducing period of time that people have psychosis. So we think in terms of our goals rather than just in terms of programmatically, because if we think in terms of our goals, then we can, it's more natural for us to be able to evaluate how the programs and initiatives that we support actually have an impact in addressing those goals.
Thank you, Commissioner Danovich. Any other comments?
No, yes,
Questions?
actually. I said no and then I started talking. Just to your point, Toby, about the different priorities. The other thing that I would love for us to explore is how we're leveraging the historic investments that the state is making in children and youth behavioral health overall, both community schools for K through 12 and the Children and Youth Behavioral Health Initiative, the $4 billion investment. And again, where we uniquely can make a contribution to that work, given the OAC's leadership and jurisdiction, as opposed to DHCS, DPH, and others. And just one area about that we, I think as child advocates, are very excited about, and I'm sure others know about, is this shift in one-on-one care to more dyadic care approaches, really considering a parent and the child as a unit when it comes to taking care of families generally. And as we heard in the medical model, it's this one-on-one transactional experience that happens. And that doesn't happen when you have a baby, right? The baby isn't taken care of without their mother or their parent or their father, their caregiver. It is a unit. And DHCS has moved forward in paying for dyadic care approaches, particularly in mental health. And it's just an incredible opportunity that I think more providers are starting to pick up and want to explore, even though it's a new space. So I would encourage us to explore this new delivery of care that I think is more responsive to culture, to family settings. It's more inclusive, and really could start to change delivery of care for many of our communities.
Thank you. Two responses. You may recall in the budget presentation that I think was last month when I was out of town. For this fiscal year, the Commission's budget includes a portion of the Child and Youth Behavioral Health Initiative funding that is dedicated to expanding access to evidence-based and community-defined evidence practices. We're still in negotiations with the Department of Healthcare Services about what that means. So the department received $429 million to expand access to the most effective practices, and 10% of those funds come to the Commission through an interagency agreement. They're still working through strategies to determine how to allocate those funds, which makes it difficult for us to figure out how the 10% that we have could be best supportive of that. So we're really working to try to do that. In terms of the dyadic care, I think as you heard from the early psychosis presentation, it's one thing to create a payment mechanism for this service. That's really important, especially if you want to scale it. It has to be fundable, but ideally easy to fund. And in the case of the early psychosis work, Medi-Cal covers much of, I think about 80% is what I recall, but not all of those costs. But what you heard today was the importance of actually providing the technical assistance and capacity building and the training. And so one of the opportunities, Madam Vice Chair, may be to use some of these funds in that 0 to 5 space to actually support the implementation of the dyadic care benefit, because that is primarily about allowing the billing to happen. It's not clear, and we don't know this yet because of the evidence-based practice money, but it's not clear if that means the state will actually be funding the technical assistance and capacity building to actually work with providers to make sure that that dyadic care benefit actually is delivered in ways that is most effective for the communities that are at highest risk. So that could be an area where these funds could be allocated. And you know, what I think staff are asking at this point is, if you give us direction of the work you want us to do, we'll go out and develop a very specific proposal to come back to you with in that 0 to 5 space, if that's what you want to do, in that older adult space. And then in you know, we could probably handle 4 of these proposals at a time. More than that will be a challenge just in terms of our capacity to get the money out and to monitor and to provide the support that is necessary.
Sorry, can I ask one follow-up really quick? So was that a way of saying we shouldn't use SB 82 funds for that?
No, it was a way of saying that that may be the best way to leverage the SB 82 funds to support the implementation of the dyadic benefit.
Thank you.
So Commissioner Tamplin and then Commissioner Willett, please.
Yeah, I really appreciate the clarity and the flexibility on some options on projects. And again, I want to, several years ago, I think it might have been 3, we went to Santa Cruz and saw Second Story Peer Respite and saw how incredible the program is. And for my own experience in overseeing county funds for Sally's Place Peer Respite in Hayward, California. And to Commissioner Danovich's point, to a model of care that's been effective, helping reduce hospitalization, increase access to care. And I would like to highlight culturally responsive services by, you know, peer support specialists that represent the community that we serve. I really strongly support that and encourage my fellow commissioners to support a peer respite project, part of this funding under SB 82. Keep thinking about 803, and so so I want to just put that out there because just to be transparent and clear. Thank you.
Thank you.
Chair, I don't have enough background on the empath model to provide a vote that I think is informed, and so I'm going to abstain on that voting, and just wanted to say that because if they are linked, the two, I wanted to make sure that it was also clear that I support Vice Chair's notion about transparency around the utilization of the $60 million. Absolutely. I, for a variety of all good reasons, support that. And then specifically, my fellow commissioner, as she spoke, as was spoken about, specifically the peer-run services and that model of service provision and how effective it is, I'll enthusiastically say you're absolutely right. And if there are opportunities to utilize those funds in that way, I would enthusiastically be in support of that. However, I might not be voting on the 60 million if they're linked together. So I wanted to make sure that I explained that one part of it is lack of information. The second part of it is an enthusiastic, absolutely, yes, I support it.
Thank you, Commissioner Willett. Please, Commissioner Gordon.
Yeah, just a brief comment to piggyback on Commissioner Alvarez's, Vice Chair Alvarez's comment. I think with the huge amount of money that the state is investing in the school-based mental health, number one. Number two, that we're taking that down now to the 4-year-old level. And thirdly, I think the fact that when we opened the Mental Health Services Act funding opportunity to counties, we had 57 of 58 of the counties took us up on engaging in that process, which I think has never come close to happening before. I think to not invest further in the early learning space to augment what is going on with the school mental health initiatives. I think people are itching to begin to work with our childcare programs, with our preschool programs, and to me, that's where much of the benefit of all of this is. If we can get to families at those very early levels, I think our chances of reducing a lot of our health disparities are the best we can make it. So, just a thought.
Thank you, Commissioner Gordon. Any other comments from commissioners in the room or online? So at this time, I want to also go back to what Commissioner Danovich said. There's a couple of ideas that have been mentioned here. And, what I'm seeing as well, and just remembering what Commissioner Danovich said, I too see substance use disorders as a big issue and find that, specific programming around that, when we look across school age through TAE into older adult, there's an interest there. So I would want to see, Toby, where I would ask staff to work with, and maybe we identify the commissioner or commissioners to work along with staff to identify and lift up, because we do want transparency and we all have, those groups that we support and have interest in. So I don't know what that looks like, and I don't want to determine it in 5 minutes, but if we can have a further conversation, and we will be transparent to it all, let's look at what exists. Let's look at where there might be a gap, and just based on the conversations that we've had here today. So for the additional beyond the 20 million that we're talking about today, so if we could, I would ask that we do that. Is that clear, Toby?
Let me just reflect that back to you to make
Please.
sure I heard that right.
Yes.
It sounds like you're interested in entertaining a vote on the proposal to support the Empath program. And the direction to staff is to come back to you to work with commissioners and come back to you with a specific proposal on access to addiction services, on 0 to 5 population, on peer respite, and on older adults. And then at a later date, we'll talk about how to prioritize the balance of those funds. Correct?
Yes.
All right. And you don't need to vote on that.
No.
That's just direction
That's
from the
direction to
chair.
do
That's
that.
right.
Correct.
If you do want to move forward with the Empath proposal,
do.
just transparency, recognize that of the $80 million, that would prioritize the first allocation of that, right? And again, the reason we did that is because we'd had that conversation earlier around the SB 82 funds.
Yes,
So,
correct.
I'm good. Yeah.
All right.
This was our hope would be that you would make a decision one way or the other on the Empath and give us this very specific direction. And we will certainly reach out to those of you who've spoken up around some of these topics to make sure that we're responsive to your priorities.
Thank you. So I'm sorry, I don't remember. Did we take a motion?
Commissioner Danovich had issued a
Yes,
motion,
thank you.
but there was no second.
Could I have a second?
I'll second that.
Thank you, Commissioner Carnevale. Public comment. At this time, we will take public comment. Sorry, lost my place. Are there any public comments? Please raise your hand now, as the queue will be closing. Amarani?
There is one virtual public comment. Angela, your line is open. You may go ahead.
Great. Thank you so much. Hi, everyone. Angela Vasquez, Policy Director over Mental Health at the Children's Partnership. Really just wanted to uplift the commission discussion around investing some of these dollars in infant and early childhood mental health programming. As I think all of you know, young children under age 5 can and do suffer from mental health conditions, although their conditions are often difficult for providers to identify and address because young children handle emotional experiences and traumatic events differently from adults and older children. In particular, we would support in expanding investments specifically in classroom-based models of infant and early childhood mental health consultation, where a clinician provides ongoing support to a child care provider rather than temporary support for a child in distress. These programs show incredible promise for reducing disparities in preschool suspensions and expulsions, particularly for Black children, and also support the social emotional development of all children in the classroom. These preventive mental health interventions are not readily available through the traditional healthcare system for many reasons, a large one being that there is not an identifiable client or patient with a medical need. These are the types of culturally responsive and early intervention supports, however, that marginalized children and youth require, and we ask that the Commission consider dedicating some portion of these funds for infant and early childhood mental health programming, including consultations within early learning and care settings. Thank you.
Thank you, Angela.
Laurel, your line is open. You may go ahead.
Good morning. I am Laurel Ben Hamida. I am with Muslim American Society Social Services Foundation in Sacramento and with REMCO. Here is my question. With the large number of Afghan and Ukrainian refugees coming into California now, many of whom are children, in the case of the Afghans, most are children, is my understanding. How will this program help those who are at risk of or already have PTSD and other diagnoses like depression, which are associated with experiences of trauma in conflict and war zones? And I hope someone will answer the question. I would like to know. Thank you.
Thank you, Laurel. So Laurel, just for the sake of time, we don't answer questions at this time, but I will ask staff to loop back with you. So thank you so much.
Thank you.
That was our last public comment.
Thank you, Amariani. Any public comment in the room?
No, there were none.
Thank you. Any other questions or comments from fellow commissioners?
A quick question about Empath. Our health plans in 14 counties, and some of them extremely rural. I just wonder, when we talk about structural inequities, are we going to specifically have some sort of allowance through this program where rural counties could actually participate? Because there's also the issue of scale and resources, et cetera.
So as outlined in the documents, what we had recommended is that at least one of these programs be dedicated to children. It was discussed at the October meeting that there's only one program like this in the country. It's being stood up in Minnesota. And given the tremendous concerns around inadequate access for psych beds for children, that this could be an intervention that actually can reduce some of that demand. We could certainly include in the proposal that there be a set aside, a designation. Typically what we do is a competitive procurement. And so we'd put some additional points for rural counties. And one of the ways to recognize that often is just to recognize that they have often a higher bar to get over because of staffing and these other challenges. And so if the commission so directs us, then we could certainly ensure that rural counties not just have an opportunity, but there's some equity built into the design, recognizing the greater challenges. Again, you heard that today in the presentation on the early psychosis work, that can be much more difficult for rural communities to access this kind of care.
Solid. No other questions or comments? Okay. We have a motion and a second that the commission approves the proposed outline for a request for applications, directs the staff to issue the RFA for allocation of 17 million of Mental Health Wellness Act funding to increase the number of empath emergency psychiatry ICU programs, and authorizes staff to enter into contracts with the highest scoring applicants, and approves 3 million of Mental Health Wellness Act funding for technical assistance and evaluation, utilizing a sole source process, which is in the public interest because of the nature and urgency of the program, and its alignment with the Goals of Welfare and Institutions Code Section 5848.5. Any additional questions or comments from commissioners? Not seeing any, I would ask Jeff to please call the roll.
Commissioner Bontrager. Aye. Commissioner Boyd. Commissioner Brown.
Aye.
Commissioner Bunch.
Aye.
Commissioner Carnavale. Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Rolette.
Abstain.
Commissioner Tamplin.
Aye.
Vice Chair Alvarez.
Aye.
Chair Madrigal-Weiss.
Aye.
Commissioner Chen. Madam Chair, the motion passes 10 aye votes, 0 no votes, 2 abstentions.
Thank you, Jeff. Okay, moving on to agenda item number 8. Staff will provide an overview of the fellowship project and will be presented with options on how best to allocate the 5 million for behavioral health fellowship project. Toby, please.
Thank you. Quickly, so last year, as part of the Commission's budget discussions, we talked about the opportunity to support the public behavioral health field by sponsoring a fellowship that would target people in this space with a focus on performance-based decision-making and disparities. The legislature agreed with the Commission's ask, and our budget includes $5 million to be made available to a partner, an academic partner, that would develop a fellowship program that really targets the behavioral health workforce with again, attention on the kinds of incentives and work that is in the Mental Health Services Act: recovery, innovation, prevention, using funds for incentives as we do with SB 82, as we have done with the Mental Health Student Services Act and some of our other programs, using data. And so the request in front of you is to authorize us to issue a competitive request for qualifications, talking with our consultants on procurement that this seems to be the best available competitive strategy to allocate these funds. Can we put the slide up, please? The proposal is that we would do a request for proposals for an academic institution that would partner with community-based organizations or others to make sure that there's adequate expertise around the behavioral health space and adequate expertise around diversity, equity, and inclusion, with a focus on reducing disparities. Based on the RFQ process, we would then work with the most qualified applicant to design a contract to work with that partner to stand this fellowship up. The design of the budget request that we made to the governor and the legislature was that these funds would be scaled to provide more funding upfront to allow planning and development with declining revenues over time, so that the partner would be able to move this fellowship to be self-sustaining through tuition, fees, donations, philanthropic grants, and so forth. But the idea is that these are seed dollars that would launch a long-term strategy to ensure that our public sector behavioral health workforce is really has access to the education and training and support modeled after the language of the MHSA, heavy emphasis on outcomes, performance, and recovery and disparities. Happy to answer any questions.
So Toby, we've talked a lot about workforce development. Would you see this as in support of some of those objectives?
Absolutely. Absolutely. As I think you heard in the presentation today, I'm just going to lean on the early psychosis presentation. The evidence-based practice that Dr. Needham and her team and our partners at Aldea and elsewhere are providing has been around for about a decade, but it's still underutilized. It's still not typical care. And so, that's evidence of some of the delays that we see in bringing most effective interventions into this space. And so, yes, this is not just about sort of growing the numbers, but making sure that the workforce that we have, has the tools and access to the training and support necessary to be as effective as possible in the kind of care delivery that's really envisioned by the MHSA. And so, you heard the story today about folks are coming out not without basic training on cognitive behavioral therapy, right? Having to start over. And so this really is a foundational investment in making sure that we can provide a resource for the workforce that we have and the workforce that we're trying to build, with attention on the issues that are necessary to drive that transformational change: performance, disparities, recovery.
Question: would the lead proposer need to be necessarily an academic institution, or could it be a nonprofit or other institution that was interested in workforce development?
So the reason we wanted to connect with an academic institution is we wanted an entity that had a significant history in the public administration field. But who the lead is actually could be determined by the partners. We wanted to make sure that we were building off of a foundation that could hit the ground running and develop this capacity relatively quickly, because we only have 5 years to move towards sustainable financing. But we also envisioned that there would be community partners. So who the actual lead is really something that can be very flexible with.
Yeah, because I'm thinking that several foundations run training programs, significant training programs. Okay, thank you.
Mm-hmm.
Commissioner Chambers, please.
I just want to echo Commissioner Gordon's remarks that I hope to see that partnership, because even though academics are amazing, CBOs and foundations are, particularly CBOs, are on the ground. We see the challenges and we can inform research to practice, practice to research. So I hope to see ideally a partnership that just does not include academic providers.
Thank you, Commissioner Chambers. Okay, I don't see any other questions or comments from my commissioners. At this time, members of the public may request to make a public comment on agenda item number 8 by clicking the raise hand button on your computer or the app, or by calling by phone *9. Amayani, I would ask, are there any public comments?
We have one public comment. Stacy, your line is open. You may go ahead.
Hello, Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. We're very pleased that there is such a fellowship. However, we hope that the RFA will be developed in conjunction and in transparency and in collaboration with people from the public, or perhaps your Cultural and Linguistic Competence Committee, if this has to do with reducing disparities. The recent project involving suicide prevention, unfortunately, for example, the RFA was put out in a way that did not really implement the intent of the legislative funds from the sponsor, which was the Asian Pacific Islander Legislative Caucus. I really ask that there is more transparency, more collaboration, and before the final RFA goes out on this, so that we can ensure that it really does reduce disparities and target people that from underserved communities, that this will be effective. Thank you.
Thank you, Stacy.
That was our final public comment.
Thank you, Amarani. Any public comments from the room?
None in the room either.
Thank you. Any other further questions or comments from commissioners? Seeing none, I would ask for a motion that the commission approves the proposed outline for a request for qualifications, directs the staff to issue such an RFQ, and to award $5 million from the Mental Health Services Fund to establish a behavioral health outcomes fellowship to the most qualified applicant.
I'll move it.
Thank you, Commissioner Gordon.
I'll
Do I have a
second.
second? Thank you, Commissioner Bunch. We have a motion and a second that the commission approves the proposed outline. Are there any additional questions or comments from commissioners? Seeing no more comments from commissioners, Jeff, please call roll.
Commissioner Bontrager. Aye. Commissioner Boyd. Commissioner Brown.
Aye.
Commissioner Bunch.
Aye.
Commissioner Carnavale. Yes. Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Rolette.
Aye.
Commissioner Tamplin.
Aye.
Vice Chair Alvarez.
Aye.
Chair Madrigal Weiss.
Aye.
Madam Chair, motion passes 11 yes, 0 no, 0 abstentions. And Madam Chair, I'd just like to correct the record. I misstated the vote on the previous motion. The previous motion also passed, but it passed 10 aye votes and 1 abstention.
Thank you, Jeff. All right, moving to item number 9, the commission approves the proposed outline.
All
that-
right, yeah. Yeah,
Yes.
for transition age youth advocacy.
Great.
Cody, if you could bring up the slides, that'd be great. I can be quick on this. I know we're
Thank
all
you, Tom.
hungry. Yeah.
You got it, Tom.
All right.
You got
Um,
5 minutes.
All right. The commission provides funds. Now it's up to $6 million a year in funding to support advocacy for these 9 specific populations. I think 4 or 5 years ago, this was maybe 6 populations. This has grown quite a bit. Recently, immigrant refugee funding was doubled, and then K through 12 students, advocacy for K through 12 students was added. And so it's exciting to see this. This presentation is for the transition age youth RFP, which we hope to release soon. Every 3 years, we come back to you for the transition age youth outline to present to you what we've done in terms of trying to hear from youth about their needs. And so our current transition age youth advocacy organization is the California Youth Empowerment Network. Over the last few years, they have provided support, advocacy, training, and education in 15 counties with 15 local organizations. This was the structure of this so that we would hear not only a statewide message about the needs of transition age youth, but also a local level message. So they were able to bring that information to the state level for advocacy, to state leaders, local leaders, behavioral health directors, MHSA coordinators about the specific needs of transition age youth. I credit Lester Rabancho for a lot of the work that was done for community engagement around this. We held 2 listening sessions. We had a focus group in Stockton with 11 youth in person. And then we presented this as well to the CLCC, the Cultural and Linguistic Competency Committee, and got some feedback about how we should move forward. So some of the findings from those events is that the young people have been severely impacted by COVID because of isolation, mostly. Being out of school was a major impact. Also financial issues, economic impacts. Underserved TAG groups lack representation. We heard a lot about negative experiences with providers who are not well trained to work with transition age youth, especially youth from diverse backgrounds. And so this is in your packet if you want to read it. Most of the comments we've summarized in a 3 or 4 page document for you. So for this request for proposal, we would provide a contract in a competitive way through to one organization, one statewide organization. It would be $670,000 per year. They would, in their proposal, provide a plan to us how they would reach local communities, counties, to reach TAY from diverse areas of the state. They would conduct advocacy efforts both at the local level and state level, provide trainings to professionals and providers. And then they would also provide an annual report, which we provide across the state and on our website. You can look on our website and see the reports that are there from the Youth Empowerment Network. We set up minimum qualifications in the outline. This is to provide us with some assurance that the eventual awardee has these qualities about their organization, that they be a statewide organization. They have at least 2 years experience in programs working with TAY and mental health needs of TAY, experience and familiarity, providing access to care for TAY, emphasizing disparities and work with underserved TAY. We will be looking for this in proposals. They have to be a nonprofit, and at least 51% of the paid staff or board members or advisory board members are themselves TAY. So next steps for this would be, if approved, we would release the RFP October 14th. We would receive proposals by December 2nd, and then December 27th, we would provide a notice of intent to award to the awardee. So if approved, the proposed motion would be that the commission approve the proposed outline, direct staff to issue the request for proposal for the TAY advocacy contract, and that the commission authorizes staff to initiate a competitive bid process and enter into contracts with the highest scoring applicant for advocacy, education, and outreach on behalf of transition age youth. Happy to answer any questions you might have.
Madam Chair, I would just add, before you have a commissioner move and second this motion, that we add a couple words to the end that just says, in the amount of $670,000 per year for 3 years to the motion. Somebody such as myself neglected to add that final clause to the motion.
Great. Thank you, Jeff. We can add that. Commissioners, please, Commissioner Alvarez. Vice Chair.
Just a comment. Tom, thank you for that. I just really want to applaud the listening sessions and the opportunity to receive valuable public input in the development of this RFP. And just want to underscore how important that public input is to the changes that you made to this RFP and really reflect the feedback that you heard from community. I've gotten comments from folks about some of those listening sessions, so just really want to applaud the commitment from you, from Lester and the team in meaningfully engaging community and reflecting that in the changes that move forward.
Great, thank you.
Other questions, comments? Thank you, Tom. I too, just based on what we heard earlier today, this population is really struggling. So thank you. I'm glad we're going to be timely on this. We will now open for public comment.
Can I say one other thing? I'm sorry, this is probably out of bounds, but
Please.
just in regards to what Commissioner Carnevale said, we also heard from Tay in the listening session and in the focus group that young people want to be involved in the mental health process and implementation and decision making. And so this is another thing we heard, and I think it reflects back to this is our potential workforce in the future. And so I think that could be another focus of this work.
Absolutely right. Please, Commissioner Chambers.
Well, just to that point, I hope in the RFP that we have incentives for those that are employing youth, because that was one of the big points that really saved my life as a youth that went through psychosis and struggled, that I did have an employment program. So definitely would love to see something like that.
Thank you, Commissioner Chambers. At this time, members of the public may request to make a public comment. By doing so, by clicking raise hand on your computer or the app, or on the app, by calling in the phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request now. I will ask that you limit your comments to 2 minutes. Mariani, please open the line for public comment on agenda item number 7. Are there any public comments at this time?
There are not.
I'm sorry?
No, there's no public comments.
Thank you. Now that public comment has concluded, or there are no public comments, we will move along. I would ask what am I asking? That the commission approves the proposed outline. I'm sorry.
No,
Would you like to?
yes, I would like to move the motion.
Thank you, Commissioner Campbell.
With the inclusion of $670,000 per year for a 3-year total of $2,010,000.
Thank you, Commissioner Tamplin. Do I have a second? Thank you, Vice Chair Alvarez. Any other questions or comments? Seeing none, I would ask Jeff if you could please take the vote.
Commissioner Bontrager, aye. Commissioner Boyd, Commissioner Brown,
Aye.
Commissioner Bunch,
Aye.
Commissioner Carnevale,
Yes.
Commissioner Carrillo, Commissioner Chambers,
Aye.
Commissioner Chen, Commissioner Cortese, Commissioner Danovich, Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Rolette,
Aye.
Commissioner Tamplin,
Aye.
Vice Chair Alvarez,
Aye.
Chair Madrigal Weiss.
Aye.
Madam Chair, the motion passes 10 aye, 0 no, 0 abstentions.
Thank you so much, Jeff. Thank you to everyone for joining us today to continue the work and discussions around mental health. We would especially like to thank members of the public. We value your input and participation. Hopefully for those of you in Sacramento, we will see you tonight at 5:30 at the Sophie Theater. The next commission meeting will take place on October 27th. We look forward to seeing you there. Today's meeting stands adjourned. Thank you, everyone.
Ramona, did you need anything before I ended the meeting?
Nope, I think I'm good, Lester. Thank you.
Okay, great. Thank you, Ramona.
Okay, thanks.